the Aga Khan University, South Central Asia, and the United Kingdom. He holds a professorship at the University of Toronto in the Department of Nutrition and Division Epidemiology, Dalalana School of Public Health, currently works at the Aga Khan University in Karachi, Pakistan. Ladies and gentlemen, I have the singular honor to introduce to you Professor Zulfiqar Bhutta. Please, a good round of applause as he approaches the podium. Thank you, young professor. Welcome.
Thank you very much for that generous introduction and for telling me a little bit about what I didn't know about myself. Actually, I don't recognize that from the introduction. So, ladies and gentlemen, my task is very simple, is to give you the background of why this project was conceived, where we are in its genesis, and I recall very fondly my meeting David Doku and Fred here in this very venue some, 7 years ago, 6, 7 years ago, and as we were conceiving the second phase of this project. So what I'm going to do over the next 25 minutes or so is to tell you a story as to why we are here today. And I can see across the room, most of you are much younger than I am, and therefore, many of the things that I will tell you about are not necessarily known to people who practice public health. So I want to take you to a different world. Only 25 years ago. And I want you to start by looking at this image. This is New York, the UN General Assembly, and 130 of the world leaders assembled at this UN General Assembly in the year 2000 to begin talking about what they could do together for the betterment of humanity. Now, the Davos meeting starts today. The world is at conflict with itself. NATO is splitting apart. The US has gone its own way. So you can see the context of this particular image and how interesting and different it is. So when would you ever see, in the context of the world, people like Yasser Arafat, the Prime Minister of Israel, standing together? Here in the first row, the leaders of Russia, China, and United States, standing shoulder to shoulder, joined by a common mission as to how they could make the world better. This was the genesis and the origin of the Millennium Development Goals. I was very fortunate to be in New York at that time as a member of my country's delegation and one of the technical working group members that actually helped define some of the targets. But this was a very different world at that time. And it tells you how the Millennium Goals were coined. The Millennium Goals, the 8 goals, were to eliminate extreme poverty, to make the world a better place, and especially through the focus on women and children. Goal 4 was particularly focused on reducing child mortality by 2/3 by the year 2015, from a baseline figure in 2000 that nobody really knew what the estimates were. So it was a guesstimate. And reduce maternal mortality by 3/4, so the figures were lower. So I told you I was a member of a committee behind the scenes that actually plucked these targets. And many people at that time, including representatives from WHO, did not have the solid global epidemiology to tell you whether we had 13 million deaths, 12 million deaths, 10 million deaths of children under 5. But anyway, this is what the Millennium Development Goals were, and they were practiced. And what happened was the world ignored them. For the first 5 years after the MDGs, right till about 2004 and 5, until we, raised some noise, and UNICEF was at the forefront of that with us in Bellagio when we put forward the numbers. And then everybody got together with global support, including countries in Africa and Asia, to do something about it. So what happened? In the Millennium Goal period, if you look at where we were in the 1990 baseline target of 12.7 million child deaths under 5, they had only gone down to around 10 million deaths by the year 2000, when we actually did the global epidemiology. By 2015, that figure had reduced to around 5.9 million deaths. And if you take the world's increase in population growth into account, this was the fastest reduction in child mortality in the history of mankind. In the entire history of mankind, we have never close to halved the number of child deaths worldwide. And we almost came close to reaching the maternal mortality target. So this was a remarkable achievement, and it only happened because we came together as the world, as policymakers, as technical people, academia, implementers, NGOs, and governments. But behind this so-called success lay several challenges and several things that were less than optimal. One of those were the blind spots. And the major blind spot in global epidemiology was that although we achieved such a massive reduction in mortality, that reduction was not equal. So if you looked at the map of the world as to where these child deaths came down, the blue countries here, they were largely big countries like China, parts of the Middle East and Eastern Europe, and big countries like Brazil, Chile, Peru, etc. But others, including sub-Saharan Africa and my own region of South Asia, did not make as much progress. So this was the issue around inequity or differentials that was entirely missed in the Millennium Development Goal period. And amongst the other issues that were ignored were things like social determinants of health, drivers, inequities in gender-related issues, differentials, and childhood did not include adolescent health. We recognized that towards the end of the MDGs. And also many things, such as non-communicable diseases, were completely left out. So the progress was not equal. And there were many challenges that became apparent towards the end of the Millennium Development Goals. So the lack of focus on pandemic preparedness, the world paid a very big price for. In 2020, when COVID virtually brought the entire world to a standstill, people looked back and said, how did we miss this in the Millennium Development Goal period? Why was there not a system put in place for global pandemic preparedness that would have allowed us to handle it? And it is because the eye does not see what the mind does not know. Many countries had not planned for this. This was not a focus during the MDGs. The MDGs only focused on HIV, AIDS, TB, and malaria to some extent as the focus of infectious diseases, but not on airborne infections or its virus bringing the world to its knees. So I'm telling you all of this because by the end of the MDGs, lots of people had got together. There was a process of discussion for almost 2 years. Through what? Through civic society groups and think tanks. The Canadian government, IDRC, put a lot of resources into helping establish think tanks in various parts of the world with a singular mission of asking people, what is it that you really want? What is it that we can do as global professionals, civic society representatives, academia, a process that was not done in the Millennium Development Goal period. I've just told you, in the MDG period, in the planning for the MDGs, there was a hand-picked group of people who were brought together to say, what can we do? And the targets were set before the epidemiology was there. This time around, we said, no, we will do a consultative process. And this was one of the longest consultative processes towards the end of the MDGs to help develop the Sustainable Development Goals. So the Sustainable Development Goals that all of you now know about, the 17 goals, did not just come out of thin air. They came out of a process of seeing what was missed in the MDGs and what needed to be included for the world to be a better place. So these 17 goals, with some 300 indicators and around 169 targets, were a process of global consultation in which think tanks played a very big role. And they were focused on looking at not just health outcomes, but the social determinants of health and many of the basic fundamental drivers of ill health, such as poverty, such as deprivation, such as lack of education, gender disparities, and also environment, the role of environment and climate change. The important thing to notice that every country of the world, unlike the MDGs, which are only low and middle income countries, this time around, every country in the world signed up to the SDGs. And even though the United States is leading the world of de-development right now, even the US signed up to it. And as we speak, they haven't withdrawn from the SDG compact. So every country in the world has signed up to making the world a better place and more sustainable in terms of development. The overarching elements of these SDGs are these 5 principles: a focus on people, a focus on prosperity, elimination of extreme poverty, peace, a focus on planetary health and well-being, and the spirit of partnerships. Now, in our thinking, the SDGs, the 17 SDGs, we put health in the middle. Not because health is the most important thing, but because it is interrelated to everything else. And that's something that you will see in the presentations today that we get to hear about, has been a dominant principle of thinking through how think tanks can influence national level thinking and development and progress. So the health and health-related SDGs, if you take the 17 Sustainable Development Goals, around about 10 of these 17 goals are very directly and closely related to health. So health only has one indicator and one goal and several indicators within that. But almost everything that you see on this SDG map is related to health. So we decided very early on, partly because I was on the UN Secretary General's independent expert review group for the MDGs, that I advocated and said, let us try and see that we don't make the mistake of the MDGs, that for the first 5 years of the MDGs, nobody knew about it east of the Suez Canal. So now that we know how long it takes for knowledge to permeate, that we should do something about it. So I, along with my colleagues, helped establish this project in the year 2016, where we said, let's look at what countries are doing in terms of reaching the Sustainable Development Goals or making preparations. And this body of work between 2016 and 20 was supported by a range of agencies that you see here, IDRC, our Foundation, and it led to 3 important documents that were published in the NDA. One was a systematic review of where countries were in that time period. The other was learning from countries, regional consultations, and national level dialogues in terms of what was needed to make things better, and a blueprint to see what could be done to implement it. This is a very important exercise, and it may look a little boring today that we did this, but it was important to do it because we learned something very quickly. We learned firstly that just like the MDG period, even though governments had signed up to the SDGs, in 2016-17, very few national level groups, advocates, or NGOs were aware of the totality of the SDGs. And very little implementation work had actually taken place on the ground. When you looked at the key findings from our analysis, not only we saw that many countries were not on target, but many of the multidimensional challenges that the world was facing, and by 2020, COVID had brought everything to a standstill. People were not prepared for it. And our recommendation in the Way Forward paper was that we should do something actively about it. And one of those recommendations was the creation of think tanks or independent, autonomous groups within countries that could be advocates and also technical support groups to the government. So the governments can't do them all. I'll tell you a very interesting story. Without naming the country, and there were two countries, where we went and had consultations in terms of the SDGs. And of a group of 20 people assembled there, we discovered that the entire SDG report was written in one office by one consultant who, if he or she wanted to, asked others. Otherwise, he just collected some documents and wrote a report. And no one in the country, none of the technical professional groups or academia had any idea as to what was the source of the data in that report. And that's generally what we recognize happens in many environments. So we said we should do better than this. So what happened was that in 2020, the world came to a standstill. I don't have to repeat what I've told you about COVID. For 3 years, nobody did anything other than survive. And then what happened after COVID was Ukraine and de-development absolutely derailed country-level work. So I estimate that we lost close to around 3 to 4 years in a focus on many of those exigencies and emergencies before people started to recognize that we only had a few years left for the Sustainable Development Goals. And today, as we speak, there is this widespread notion that the Sustainable Development Goals will not be achieved, or that they do not necessarily represent priorities in many countries. So we asked the Canadian government and the Aga Khan Foundation to see if we could experiment and see if think tanks in countries could help accelerate at least a discussion around SDGs and progress. And that's the genesis of the project that we are discussing today. This is the final meeting of a series of 5 countries that have looked at this, in addition to a global exercise. And I will not steal the thunder of the Ghana team in telling you how they've gone about it. So I don't have to tell this group that the SDGs are indeed off target. And I will not bore you with statistics in terms of how poor things are. I'll just probably point out 1 or 2 things. And you can see the detail, a lot of that in relation to maternal child health, adolescent health, in this countdown report that we published last year. I chaired the countdown process for 13 years. I know how rigorous that process is in looking at indicators, trends, and you can get a lot of that detail in this open access report in the Lancet from last year. And it basically makes the point that we still have those challenges of disparities. We still have those challenges of de-development, and we have the challenges of additional contextual issues in many parts of the world that relate to maternal child health. And you can see very clearly that although there is reduction in all regions of the world, in all age groups, that reduction has slowed. So the reduction in mortality is not a straight line. And as we go to a lower figure, things plateau, and therefore getting to the targets that were set will be a lot more challenging than people thought. Nutrition is another area. And I wanted to talk about nutrition today because we have done a case study in Ghana on how stunting reduces. And Ghana is actually an exemplar country for reduction in stunting. So you can do a lot with less, provided you have a policy focus. So congratulations to the Ghanaian government and civil society for having done a lot in terms of reduction in stunting. Okay, now I do want to talk about what's happened to money. Now we recognized, even before the US government changed its policies, that development assistance had started to reduce. Part of this was COVID. Part of this was, as I said, wars and changes related to this. But in the period between 2016 to 21, both of those things led to a significant reduction in money for child health, for maternal newborn health, and also for reproductive health worldwide. And these 4 to 10% reductions in budgets or development assistance are pretty significant. And now they have accelerated quite a lot. But there was another thing that became very apparent, and I'm very pleased that both for Fred and David, that you have taken on this mantle of additional contextual challenges. And that related to what was happening with climate change. People think climate change does not impact Africa, only impacts countries in Southeast Asia. Nothing could be farthest from the truth. North Africa, just a year or so ago, had a record heat wave that impacted the Sahel region, North Africa in particular, not seen in over 300 years. And also the complex interplay of climate change, migration, and conflict. So in our countdown report last year, we actually published this map. I want you to see this map for a minute. This is a map of conflict and displacement. And you can see that the number of people who are affected by conflict and displaced is maximal in North and Central Africa. And this is why, because the interplay of climate change, limited resources, migration, also leads to insecurity and conflict and impedes development in many contexts. So we recognize that as we move forward, ignoring these contextual challenges will be to our own peril. And of course, since January last year, to this climate, conflict, undernutrition, food insecurity nexus, we've added a fourth challenge, which is an absolute reduction and disappearance of development assistance in many contexts. I do a lot of work in conflict settings. I'm saddened to say that in one of the most ignored conflicts in Africa, in Sudan today, which affects close to around 25 million children in that country, development assistance has all but disappeared. We are now at a level of 15% in terms of humanitarian support in the largest humanitarian crisis of Africa. So something is very wrong in terms of how we are prioritizing who we help and where. So in our next phase, we've done several things. We've done things centrally as part of my own work group in Canada and in Pakistan. And we have done things with country partners, including the work that you're going to see from Ghana. So the two things that we have done in this consortium is look at progress periodically. So we updated our progress report from 2016-20 to 2025, and we have looked at national and subnational challenges of climate change, environment, food security, and development parameters. We've done this in 5 countries. 3 of those countries are in Africa: Ghana, Tanzania, and Kenya, Pakistan, and Kyrgyzstan, Central Asia. They were deliberately chosen because these countries had expressed an interest in doing something about this on the basis of the findings. The project activities consist of things that are done at a country level, which is to look at national, subnational changes and progress and what development parameters are within the line of sight of governments, and things that I've just mentioned, such as looking at systematically what has changed and also the contextual challenges that I'm talking about. So for example, with our technical advisory group that is mentioned here, we had to set this up. This is a very high-level group with global experts who have helped take this forward. We've had annual meetings where we have brought people together and for them to have guided us. We met a year and a half ago, and then very recently, a couple of months ago, to review progress. And I'm going to just summarize this in a couple of slides. So first of all, our systematic review looked at the same approach of looking at the lens of several SDGs in terms of progress across countries, low and middle income countries, And we added an additional SDG of climate change, where we looked at data across all of these countries. And as you can see from this map here, indicators for many of these countries, in many of these targets, are still very variable. For some, we have good indicators. For others, we have fewer indicators on an annual basis. But of these many reports, we now have progress reports from Africa. You see these in the countries here. Importantly, also from South Asia. So 149 studies now, compared to just 15 studies at the time when we looked at it last time, is a very good indicator of how, despite all the challenges, Africa is still taking the lead in terms of looking at how sustainable development goals can be achieved. The key findings from our review are that there are national level policies and political commitments still around sustainable development goals, and particularly these health-related sustainable development goals. They target women, children, and refugees. Many of these, very rightly, are multi-sectoral approaches. So countries are not restricting these planning to only. Increasingly, it is looking at social protection, and despite the monetary challenges, many countries are making resources available. I was very pleased, particularly, to note that from my last trip to Ghana to now, there is not only more affluence and progress, but there are also more resources being added to many of these issues, which is an indication of government's prioritization of social sector and related sectors. Obviously, we could do better, but certainly this is an important finding. There is greater focus on decentralization in many countries, devolution to a subnational level and targeting areas where progress may be less evident geographically and also to sectors is being done. In East Africa, there is greater awareness now of the importance of urban poor, slum populations, and also areas where climate change and environmental degradation are holding back progress. And there is greater focus in Africa on capacity development. Now, unfortunately, there is also a huge human resource drain out of Africa. So you're building capacity, but you're also losing capacity. And that's not just Africa's fault. That's the fault of high-income countries that are now absolutely brazen and without any shame targeting the most well-trained, the most capable people from low and middle-income countries for their own development. Yesterday, United Kingdom announced an incentivized scheme for bringing in IT professionals from low and middle-income countries. 20 years ago, this would have led to an outcry. Because if you suck up all the well-trained people from low and middle-income countries, who will be left? We saw that with nurses, we saw that with doctors. But today, in this new nationalism, high-income countries are doing this brazenly and will continue to do this because they want to, quotes and quotes, bring the best and brightest without having to pay for them. So when you bring a health professional or an IT professional to your shores, it is the low-income countries, the low and middle-income countries that have paid for that education, training, and all of a sudden have lost the person. So this is a huge global developmental challenge. So the challenges beyond today that I hope we'll discuss in the general discussion are around what happens after 2030, which is just 4 years away. What do we do with polycrises? And how do we get information? Now, the reason why information is so important is because the world had become dependent upon the United States and USAID and UNICEF funding surveys. Very few services had been focused on developing national monitoring and data systems. The demographic and health surveys, the multiple indicator cluster surveys are the backbone of what we have for information systems. The frequency of multiple indicator surveys will go down because there is less money, and demographic and health surveys have disappeared. Just to complete the surveys that had already been implemented, we had to depend upon the money from the Gates Foundation. But going forward, there'll be no demographic and health surveys. So countries will have to come up with their own system for monitoring. And this is a big challenge. I'm talking today because I have the data. In 5 years' time, I'll have no data. I'll have just modeled information. So coming back to Ghana, I'm just going to show you 3-4 slides of the kind of work that we have done in partnership with our colleagues here in looking at national and subnational changes. This is largely around environment. So looking at a range of, and thank God, this does not require data collection. This is remote sensing. So satellites take this information, and we sometimes couple it with other sources of information. And this is also an issue. I'd love to hear from you, Fred. What does this do about data sovereignty? Yeah? Today we have done this in partnership with you, but tomorrow somebody will be able to do it without even talking to you in terms of what are the data for Ghana. So here is what has happened to temperature change in Ghana at regional level. It's all satellite collected information, pretty accurate in terms of what is wet bulb temperature, which is a temperature and humidity interface. And what has happened to precipitation in different places of Ghana. And you can also look at what happens in terms of displacement related to natural disasters, which generally are floods in this part of Africa. And as you can see, many of these also lead to displacement of people. So I'm only giving you these snapshots because we have been able to do this for many of these countries and to see how these contextual challenges are impacting health progress and health-related SDGs. To finish, ladies and gentlemen, we believe that as we end this project and hand over many of these things to our national partners and think tanks, that progress is possible. Ghana is a very good example of a country where, despite all challenges, the fact that I believe your current government is just a year in place or less than a year in place, about a year in a few days, right? So that's remarkable. Have been able to keep a democratic process going, have been able to maintain democratic change and progress, and that is very good hope for the future. So many of these countries are also countries where I think we will learn in a few years from this process of public-private partnership and academic collaboration. Well, thank you very much for your attention. I am very keen to learn from you, and I hope we'll have time for discussion. Thank you.
Please, a good round of applause for a professor to give us special remarks. It's a full lecture on the status of implementing the SDGs. Professor Bhutta, we are very grateful. So next on our agenda, and the two of them who will hold us for our snack break will be Professor Teye Doku, the country lead for the PICHOICE project and a member of HHSDGs think tank group, and the National Development Planning Commission. So if by 11, these two team members have not done with their submissions, we can hold them accountable for standing between, standing in the way of our snack break. So we'll be waiting for Professor Teye Doku to take the podium and give us a background to the health and health-related SDGs think tank in Ghana. Yes, please. But thinking through Prof's submission, linking to urban poverty, placement, thinking through the climate incidences or the records that we are having in this country, talking about the maternal child mortality, bring the lines of the plateauing. We are making progress, but progress dips and then plateaus at a certain point. It puts my mind to thinking about the extra effort that we always need to get to the last mile. When you look at all this data, think just in the last week before we went on Christmas break, Ghana Statistical Service churned out a number of research reports, and the last mile actors contribute significantly to our progress indicators. If we do not reach out to those who are nearly lost, left behind, do not have the voices, and we cannot even find them, then it means that we are having a long way to reach on the SDGs. Prof is here. I hand over. Thank you.
Thank you very much, Technical. Okay, thank you very much, and Professor Bhutta, we are very grateful for very, indeed, insightful presentation and thought-provoking discussions about where we were as a united people, humanity, working together, and how we have become now. And something that is really striking is how much we have lost because we want to be separated, because you don't want to work together anymore. And this is something really that we have to be thinking about. United, we say we stand, and when we divided, we fall. And let's see how we can reflect that, irrespective of where we work in, whether civil society or academia or policymakers or policy implementers. These are really very thought-provoking issues that we need to be thinking about and taking home. So I would like to share with you briefly about what the HHSDG think tank did, and a few reflections also on what we have found working together, and want to invite your comment and also your contributions, how we can work forward from here. We still have a little technical challenge. When I was here, it was okay. So when I leave here, you just leave it as it is. Just 1 second. Okay. All right. So, okay, you can change the slide for me. This next. Hope I can. Okay. Right. So I'll be talking about the project objective, some highlights of our activities, and then some key findings, and then some reflections and sustainability, where we're going from here. So our Prof. Bhutta has said a few things already, but our goal as for this project, the HHSDG think tank and Ghana's arm, is to create or activate in-country multi-sectorial think tank to facilitate work towards achieving the health and health-related SDGs. And Prof. Bhutta has highlighted what in our context we have adapted as these health and health-related SDGs. As part of that, we intended to we intended to conduct country studies and also to monitor and evaluate progress towards the HHSDGs. Next. Next, please. We also wanted to create a global consortium. As Prof. Bhutta has said, there were partners working in Kyrgyzstan, Pakistan, Tanzania, and Kenya. So by working together, we are creating that, and I'll share with you a little bit how this is unfolding in other dimensions, especially in the area of climate change and health. Next, please. So we had a number of activities. One of the key issues was to form the HHSDG think tank. Then we did a scoping review to track the implementation of the SDGs in Ghana. We know that the NDPC were at the forefront of working together. And the previous government, we have a whole desk at the presidency. When we did the inauguration here, we had a person in charge at the presidency here and all that. But we also know that there are packets of data, gray data, so to say, that are not at the forefront. And as Prof has said, the intention is not to sit somewhere, maybe at UCC, and then write a report, but also to see what others are working on and what data we can have so we can have a holistic view of what the situation is in the country. So we did the review, and the review was to provide a baseline national institutional analysis of the HHSDGs. I'm happy to say that the full review has been accepted for publication, and it's open access. All of us can have access to read. We're going to share a few excerpts here, and we also circulate on the mailing list for this meeting. Then so I said, yeah, we have a manuscript which is gone for publication. Next. Next, please. Next. We formed a think tank. The goal is to have multi-sectorial think tank that is made up of academia, civil society, practitioners, policymakers, and so on and so forth. So I'm just going to run through Ghana here, how we did it. We have the National Development Planning Commission represented, which is a governmental organization. We have the Gender Department of the Ministry of Gender, Children and Social Protection, a coalition of NGOs in health, and a vision for accelerated sustainable development. We had Ghana Monitoring and Evaluation Forum. We have Green Africa Youth Organization, Basic Need Ghana, Ghana National Council on Persons with Disability, University of Cape Coast, University of Ghana, Kwame Nkrumah University of Science and Technology, University for Development Studies, and representation from the United Nations Population, UNFPA. So we have a cross-section of this institution. There were a few reps that we invited and they declined. And the reason initially was a little bit misconception about what at all is a think tank. Because what we have known a think tank to be is somebody, an institution or organization that is keeping the government on its toes. Sometimes they can be politically aligned and so on and so forth. So one response that we got, for example, was one UN arm that is saying that, no, we want to support national development. We don't want to be aligned and so on and so forth. So this think tank was too much a thing for us to involve in. There were others who expressed similar views, but as we explained to them what exactly it was, that this was a think tank like no other. A think tank that is rather supposed to work together with the government and provide some insights into what the government is doing to support what we are doing collectively so we can build the country together. Then a couple of them came on board. So I think it was a similar reason why WHO declined. And I should say that even UNFPA, we went back and forth with discussion about that before finally they get on board. So these are the members that we have had. You would like to be looking at me, please. Arrow, next. Next, please. So we coordinated this from the University of Cape Coast because the project and the contract was made between our global partners and the University of Cape Coast. And these are my colleagues. Some of them are here who help in the coordination of the project. One, we intended that whatever we develop, we put it in an easily digestible format so we can share. We have a few of them here, and we will share more. We have circulated them already through our think tank and the reps, and we'll share a bit more as we go along. Next. Keep finding, yes. So we were able to look at progress on a number of the SDGs. I'm sharing 5 here. Ghana's progress towards the attainment of 5 SDG goals. Go 2, 3, 5, 6, and 13. And the colors here signifies, if it's red, then it's major challenges. Arrow showing stagnation, some at some point, and then the yellow here is signifying challenge still remain. Green, that there's some achievement or some goals are being on track and so on and so forth. So there are things that are on track, but if you look at the details, there are aspects that really needs a bit more data to understand whether the achievement is uniform in the country or when you pick some regions, it's not the same. And one of the key things that we wanted to do, which we have not actually seen in the national report, is the disaggregation of the result across regions. And as Prof. Bhutta has said, and myself as a social epidemiology and inequality researcher, sometimes achievements are made, but how are these across sections? How are these? At the national pool, you do see that very much, whether everybody is benefiting from the achievement that have been made or not. So Ghana's progress towards attainment of SDGs. Ghana has made significant progress towards the achievement of 5 of the SDGs. 2, 3, 5, 6, and 13. And cumulatively, you said 10% of the SDG 2 target has been achieved, whereas less than 10% are on track to achieving. However, 50% of the goal require acceleration for their target to be achieved, and close to 30% of the goals had data gap. Data was one challenge, and my colleague from Ghana Statistical Service, who was also my master student, my mentee, is there. We know that data, one of the issues that debate that we had, even on the think tank, is no, there's data here. But we know that for data to be really available, it should be findable, interoperable, it should be accessible, and it should be usable. And in fact, even reusable. Sometimes the data is available, it is not accessible. So if the data is available, it's not accessible. Sometimes the data is available, it's foundable, it's not usable. So all these things should be met. And I hope that during the discussion you can share your thoughts on our data that is available. Is it findable? Is it accessible? Is it interoperable? Can we integrate that data, have data, for example, with climate change data? Or are they in silos? Can we use them? Can we reuse them? And so data gap was a major thing that we found in accelerating progress. And you cannot intervene as practitioners, as scientists, and so on and so forth. You know that you cannot intervene in vacuum. You need to know where you are, and then you'll be able to intervene. So data is one thing that we really, really have to work on, whether we need additional or they are available and we want to make them available and usable. Next, please. So we have 13, for example, we see the green is telling you the proportion that is on track, blue proportion that is unmet, proportion that needs acceleration is the yellow, and red is stagnation, and then the gray is where we do not have sufficient data, and it's huge. And when we show this, there is always the debate, we have the data. Where is the data? Where is the data? And I think my colleagues from the National Development Planning Commission is also here. And so it is important that we share the data and make it available so we can be able to gauge what is going on. Then we were able to, this is one of the few reports that has this perspective that has been disintegrated into urban and rural and also regions. And at the time we had this is how it was looking at, in fact, in 2023-24. Yellow here again, the blue means that the goal has been met. Green means that on track. Yellow means acceleration is needed. And then red, stagnation, and data is insufficient or unavailable to be able to gauge that. We've been able to see that even where progress is made, it is not uniform across the regions. And there could be disparities between urban and rural areas. And this is very, very important for us to see. From this, we have developed very quick infographics that we can share with lay people or young people or whoever that do not need very technical information to be able to appreciate where we are and what we have found and what we can do to accelerate progress. So a few infographics, we have developed them and we are circulating them through the think tank to ensure that it is widely circulated and we can hopefully accelerate interest in making progress towards achieving some of them. 2023 is so close, but we still think that we can still do something to be able to reach where we want to go. Next, please. So the conclusion is that Ghana has made moderate progress with respect to, for example, SDG 6, SDG 5, but there are challenges in that. Progress has stagnated with respect to SDG 2, SDG 3, and there are still major challenges with regards to this. Next, please. We recommend that availability and accessibility of data is very, very critical in monitoring progress. Available, accessible, and it should be usable. The use of real-time data and monitoring tools, offline data collection and management system, and possibly dashboard to facilitate continuous and effective data entry and data analysis. And start back, is it? Yes, Ghana Statistical Service has introduced that and they've worked a lot on that. But I'm still wondering, do you have a possibility to track, for example, how many people are able to access that? How many people are able to access that and monitoring who are they who are using this data and so on and so forth is very, very important. I was happy then that was launched at the University of Cape Coast, but that shouldn't be the end in itself. It should be a means to knowing whether it's being used and whether it's really benefiting the people. So there is a need to engage all necessary stakeholders, and I'm happy we have a cross-section of stakeholders, very, very important stakeholders in this room. We need to engage, and this today project may be ending, but it should be the start of additional engagement that we can work together and see how we can do that. So we have to form a really, really strategic synergy that we have to work together. We are opening a call for climate change and health research. We need to work together. Climate scientists shouldn't work in silos, for example. Health scientists shouldn't work in silos. Nutritionists should work with climate scientists and migration experts should work together. So we should be able to work together because these challenges are not in silos. They are related. We need to, please let's go back to the last one. We need to, back. Yeah. We need to sensitize the public through community involvement, including citizen science. The people should be involved, and we know that when people are involved, they own the process. Ike has done it so great. They said if the person builds the thing, he values it and he owns it. So people are happy when they are part of the process, and we are happy that you are part of the process. We need to engage more on that, to engage our buy-in and all the policy interventions that we put in place so we can support them at every level. Where do we go from here? I believe Prof. Bhutta will share some thoughts on that as part of his closing remarks. But we as Ghanaians, we as think tank members, we as development partners, we as civil society organization, as academia, where do we go from here? One of the things that we have attended a lot of engagement like this, workshops and seminars. And one of the things that we always cry is that when the funding runs out, the project ends. and nobody talks about anything anymore. We want to take a different approach as a think tank. We want to move on. One of the think tank members told me 3 days ago that this think tank has come to stay. Yes, it has come to stay, but how do we fuel it? How do we harness resources, hunt for resources to fuel it? How do we make our own contributions to fuel it? Is a key issue that we need to think. We need to form partnerships. We need to explore avenues for collaboration with government and non-governmental organizations to facilitate access to data. Ghana Statistical Service, we have to forge partnership with you. Access to data, to secure technical support. Maybe UNICEF, WHO, Ghana Health Service, we need technical support when necessary. We have to forge partnership to be able to do that. And to mobilize funding. We can work, but snack is there. We can work on empty stomach. There are things that we need a little resources to be able to do. So we need to also see how we can mobilize resources to be able to do that. We have to get buy-in from all of us, stakeholders and decision makers, to be able to ensure ownership and sustain engagement going forward. We have to make sure that there is availability of funding. Team, we intend to continue to see whether we can produce reports. We have also charged our members to hunt for a possible call for proposals. We were very fortunate that just at the tail end of this project, we got funding supported by IDRC to fund about 20 projects, which is looking at the nexus between climate change and health across West and Central Africa. And we are using our think tank network to also encourage members to apply. It's for West and Central Africa, so the pot is not that big. It means that we can just fund about 1 or 2 per country, but it's a good start. And we're hoping that with that collaboration, we can be able to also get some resources to look at different aspects of the HHSDGs and move the process forward. We have to probably think about how we can diversify funding. So, for example, for KUST, the universities and things like that, when you are writing a proposal and you are looking for partnership and things like that, you can think about people within this network who can support to work together and things like that. We have been challenging on another level and universities to see how everything they do also contributes to the SDGs. That's very, very important. And I think in Ghana, a few of them are a bit excited because they are also interested in the Times Higher Education World University Ranking, in the impact ranking, which actually looks at their role in pushing the SDGs, the Sustainable Development Goal. I think now it has been changed into sustainability ranking, but I think they're also interested in that. And these are always, so we should look at all possible innovative ways by which we can raise resources to be able to continue the work that we do. And I will invite thoughts that we can share on this going forward. We have to work together and move the process forward. Next. So I want to thank you, and I want to thank especially Professor Bhutta for inviting us onto this project and working with us for this couple of years. We have learned, we as think tank members have learned a little bit more about our own country through the process of working together on this project, and we are very grateful. We're looking forward to forging even stronger partnership, both among ourselves and also with our global partners, so we can continue to work after today. Thank you very much for your attention.
Thank you very much, Professor David Teye Doku. So I'm not wasting much time. We have the owner of our development, the institution, that is at the apex of Ghana's development agenda, setting the indicators, doing the monitoring. I have the pleasure to invite a senior planning analyst, my very own Mr. Michael Kisi Boateng, to give us a keynote address on behalf of the Director General for Ghana, the National Development Planning Commission, Dr. Audrey Smoke Armah.
Thank you very much. Madam Chair, please permit me to stand on existing protocols. For those of you who may not be aware, Madam Chair used to be a vice chairperson of NDPC some time back. I know she didn't want me to say it, so I didn't look at her face, but I've said it. All right, thank you very much. Prof, that was very insightful, your presentation. And I'd like to say that the SDG advisory units that you talked about at the president still exists. And this time around, the one who heads the unit is also the chairman of the National Development Planning Commission. Yes, so in dealing with NDPC and dealing with them, you are in the same family. So the work continues. Thank you very much. I am honored to address this august gathering on behalf of the National Development Planning Commission at this important multi-sectoral engagement on Ghana's sustainable development goals with specific focus on health and health-related sustainable development goals, what we refer to as HHSDGs. Let me start by commending the organizers and partners for convening such a strategic dialogue. The complexity of the SDGs agenda require exactly this kind of platform, one that brings policy leaders, implementers, researchers, development partners, private sector actors, and community institutions together to reflect, recalibrate, and recommit. Health is not simply one of the 17 global goals. It is a central pillar of sustainable development. It underpins productivity, social cohesion, poverty reduction, education outcomes, gender equality, and economic competitiveness. At NDPC, we consistently emphasize that national development planning must be human-centered. When populations are healthy, their labor productivity improves, school completion rates increase, household resilience strengthens, and long-term growth perspective expand. Conversely, weak health systems increase poverty, vulnerabilities, deepens inequalities, and constrain economic transformation. For this reason, health remains firmly embedded in Ghana's national policy framework and medium-term development strategies, sector alignment processes, and annual performance reporting systems. We continue to streamline and mainstream health-related indicators into district planning processes and ensure coherence between national priorities and subnational implementation. Ghana's implementation of health and health-related sustainable development goals have recorded important progress over the years, anchored in strong national leadership and a coordinated implementation architecture. The integration of the sustainable development goals into our medium-term development framework, sector policies, and district development plans, supported by regular performance reporting and monitoring systems, has ensured that health priorities remain firmly embedded in national decision-making. This whole of government approach reinforce high-level coordination through the Office of the President, the National Development Planning Commission, and the Ministry of Health, continues to drive alignment and accountability and results across the sector. We have expanded geographical access to health services through the CHIP programs and new facility developments. Immunization coverage has remained a cornerstone of preventive health care. Primary health care delivery has been strengthened. Community outcomes and public health education have expanded. Service utilization have increased, particularly for antenatal care and skilled deliveries. However, we must also acknowledge that progress has not been uniform across all indicators and populations. And I'm sure those of us who paid attention to Professor's presentation realize there are disparities between the performance in our rural areas and our urban centers. Health outcomes have always kept pace. Health outcomes have not always kept pace with service expansion. Persistent disparities remain between rural and urban areas, between northern and southern regions, and between formal and informal settlements. Quality of care challenge continues to affect patient outcomes. Financing pressure influence system sustainability. Human resource imbalance persist. Supply chain vulnerabilities occasionally disrupt essential services. These realities underscore the fundamental lesson that SDGs coverage alone does not guarantee impact. What matters is quality, equality, resilience, and service integration. Maternal mortality remains one of the most sensitive indicators of health system performance. Despite high antenatal coverage exceeding 80% of nationally and facility-based delivery rate estimated around 86%, Ghana's reduction in maternal mortality has slowed. The data shows that maternal mortality declined only marginally from 310 deaths per 100,000 population in 2010 to approximately 301 per 100,000 live deaths in 2021. So within a space of 10 years, we haven't really achieved much, and we need to double up. Remaining and the thing about this is that the target for the SDGs is supposed to be 70 per 100,000 live deaths. So it means that even if we multiply the target of 70 by 2 times or even 3 times, what our performance will still not be up there. So we really have much to do as a nation. So such a dialogue here is very important for us. More recently, administrative data indicates that close to 900 maternal deaths were recorded between January and November 2025 alone. This is very serious, and it's something that we really have to work hard as a country. These figures demand sober reflection. We have observed that the challenge is no longer it's no longer primarily about access. Rather, it is about systemic performance, quality of care, emergency obstetric readiness, referral efficiencies, availability of blood and essential commodities, staffing adequacies, supervision, and accountability. They also review deep inequalities. Some rural areas and northern regions continue to record maternal mortality rates exceeding 450 deaths per 100,000 live births. So this is way higher than the national performance. The national performance currently is at 301, but in these regions that I just mentioned, they go beyond 450. So it's quite concerning. While part of Greater Accra records below 200. So in Greater Accra, at least we come below the national average, but it's still not enough because the target is just 70. Yeah, 70 per 100,000 live birth. Such disparities point directly to unequal infrastructural distribution, workforce deployment, transport networks, and social determinants of health. Recognizing the urgency of this challenge, government has elevated maternal mortality reduction to the highest level of national priority. His Excellency the President John Dramani Mahama tasked government to prioritize the reduction of maternal health across board in the country, and he did this during the launch of the 2025 Voluntary National Review Report and at the presidency. A high-level roundtable engagement convened in December 2025 by NDPC and the Office of the President with the support of UNFPA marked the beginning of a presidential-driven effort to accelerate progress in a coordinated and comprehensive effort at reducing maternal mortality in Ghana. This reflects a clear understanding that maternal mortality is not only a health issue, it is a governance issue. It is a social justice issue, and it is a development imperative. SDGs are designed around interdependence. Therefore, HHSDGs cannot be delivered by the health sector alone. Emergency referral depend on effective road networks and transport service. Reliable electricity supply determines the functionality of theaters, laboratories, and cold chains. Water and sanitation systems shape disease transmission patterns. Education systems influence health literacy and early pregnancy preventions. Social protection programs determine household resilience and service utilization. Environmental management affects disease vector and climate-related health risk. This is why Ghana's development planning architecture continues to prioritize multi-sectoral coordination. At NDPC, we work to ensure that sector plans are aligned with national priorities and that district development frameworks integrate health considerations and interministerial coordination is strengthened around shared outcomes and indicators. This approach ensures that not only maternal health, but the full health and health-related SDGs agenda, including non-communicable diseases, mental health, environmental health, pandemic preparedness, nutrition, and food security are all included. It has long been established that primary health care remains the backbone of Ghana's health system and the central pillar of HHSDGs implementation. Government is prioritizing the completion of chip compounds under construction and expanding new chip facilities to improve geographical access to essential services, especially for rural and underserved populations. Traditional primary health care services will be made universally accessible through CHIP compounds, health centers, clinics, and polyclinics. Market and transport station clinics will be established to provide basic health care services for traders, drivers, passengers, and informal sector workers who often face access barriers due to working hours and location constraints. School health services are also being strengthened. School sick bays in boarding institutions will be upgraded in satellite clinics and satellite clinic staff by health professionals to ensure 24-hour healthcare and promote referral services for students and teachers. Mobile outreach programs such as Unuado and Unipenua medical and dental services are being reintroduced to reach rural areas and island and disadvantaged communities to bring specialist care closer to the population that would otherwise remain excluded. Preventive health care remains the most effective investment for sustainable health outcomes. Government is strengthening disease prevention through the implementation of a national vector control program alongside the Ghana Malaria Prevention Program. Sustainable sanitation practices are being scaled up to reduce malaria transmission and environmental health risk. Regular screening for cervical, breast, and prostate cancer is being expanded nationwide to support early detection and improve survival outcomes. Collaboration with research institutions are being strengthened to enhance disease surveillance, improve monitoring of health data, and generate periodic public healthcare alerts to support evidence-based decision-making. Mental health services are being integrated into primary healthcare delivery. District-level hotlines and e-counseling services under the National Health Insurance Scheme framework will be improved. To strengthen pandemic preparedness and response capacity, government is investing in international partnerships, epidemiological surveillance systems, and strategic coordination platforms to improve early warning mechanisms and rapid response capacities. Health security today requires a holistic and integrated approach. Government is fully operationalizing one healthcare framework to safeguard Ghana's population from zoonotic diseases and antimicrobial resilience, food safety risk, and climate-related health care threats. This involves strengthening coordinated actions across human health, animal health, and environmental sector, anchored on improved surveillance systems, shared data platforms, and joint emergency response mechanisms. As climate change intensifies health vulnerabilities, this integrated approach will become increasingly critical for national resilience. It is important to recognize that no health system can succeed without a motivated, protected, and well-trained workforce. Government is introducing a comprehensive health care health worker development scheme to strengthen professional capacities at all levels. A healthcare migration policy framework is being developed to promote ethical recruitment practices while safeguarding domestic healthcare workforce sustainability. These measures are essential for improving retention, morale, service quality, and equality in healthcare distribution. Health and equity in workforce distribution. Sustainable financing remains a central point in HHSDGs achievement. Government is accelerating the implementation of the Ghana Medical Care Trusts Fund, known as Mahama Cares, to support the cost of treatment of non-communicable diseases such as kidney failure, cancers, and cardiovascular conditions. Reforms are underway to strengthen national health insurance scheme by protecting health-related revenue, improving reimbursement efficiencies, and closing financing gaps that affect service delivery. A fund retention mechanism will be introduced in the chip level to ensure undisrupted 24-hour service delivery at the sub-national levels. Budget allocations to primary health care deprived districts and underserved communities will be increased to improve equality in access. Tax and tariff on vaccines and medical donations on public health facilities will be removed to reduce operational cost and improve service availability. Government is completing stored health infrastructure projects and expanding regional hospital capacities in underserved areas. Central Bed and Emergency Management Bureau will be established across southern, middle, and northern belts to strengthen referral coordination and emergency response efficiencies. A centralized health information management system will support secured sharing of patient data across hospitals in compliance with national data protection regulations. Telehealth platforms will be upskilled nationwide to improve access to specialist care and reduce referral delays. A patient protection council will be established to regulate service standards and strengthen accountabilities across public and health facilities. The private sector remains an important partner in health service strengthening. Franchising arrangements will enable private providers to operate diagnostic, dental, pharmaceuticals, and specialized care services within public hospitals based on international best practices. Government is also promoting health tourism by retooling selected facilities to international standards, strengthening tertiary hospitals, and repositioning Ghana as a competitive medical tourism destination within the West African sub-region. This creates opportunity for job creation, foreign exchange earnings, and health sector improvement. Distinguished partners and participants, NDPC reaffirms its commitments to achieving all health and health-related SDGs. Our mandate remains clear. We will continue to prioritize health outcomes in national development policy framework, strengthening sector coordination, integrate SDG indicators into district planning systems, and improve performance monitoring and accountability mechanisms. We will also deepen partnership with ministry departments and agencies, local government, development partners, academia, civil society, and the private sector to ensure that health investment translates into measurable development outcomes. The HHSDGs present not only challenges but also opportunities. Opportunities to strengthen digital health systems, opportunities to expand domestic health financing, opportunities to build resilient supply chains, opportunities to reposition Ghana as a regional health service hub, opportunities to transform community health delivery. But these opportunities can only be realized through coordinated action, institutional accountabilities, and sustainable political commitments. In conclusion, distinguished participants, health is not a cost to manage, it is an investment to protect. Through strong leadership, multi-sectorial coordination, and consistent implementation, Ghana can achieve health and health-related SDGs and build a resilient health system that supports inclusive growth, social stability, and long-term national development. Let us leave this workshop with renewed commitment to translate policy into results, ensuring that no Ghanaian, whether in private, urban centers, or remote communities, is left behind. I thank you.
The Apex institution telling us our development agenda and the opportunities that lie ahead of us, bringing together all stakeholders to move forward to achieve sustainable development for Ghana. Once again, a round of applause for Mr. Michael Kisi-Boateng. We will be pausing for our snack break, but on our agenda, we have a photography session. So, dear members, we have been sitting for a while. We haven't stretched. Because of time, we are not going to do the exercise, but in between, after our snack break, we'll be doing some exercises. So we'll be taking the picture right here. So please, gentlemen with muscles, please help us relocate our podium, and then a few seats to get our distinguished partners and our chair lady seated. Labram, please, are you here? Okay. Please, shall we be upstanding and then come forward? Come forward, please. Thank you. Madam Chair. Prof. Atuama, please, Mr. Kisi-Boateng on the chair. Madam Dazi, please. Prof. Bhutta. Yes, please. A little gender balance. Some gender balance. PRO NDPC. Okay. Yes, please. The gray will look beautiful in the picture. I'm not mean. My tummy flat. Okay, please, it's time for snack. Thank you very much. Please, for the sake of time, let us do some 15 minutes and then we are back to our seats. Thank you very much. Hello. Okay, thank you very much. We are back from our snack break. We can be working while eating our snacks that are still left on our plates, but please make sure you've had something to eat. So just coming back in 30 seconds so that we can settle. Thank you. Hello. Okay, thank you all very much. We make progress, Madam Chair, with your kind permission. Our item on the agenda is presentations on the progress towards the achievement of the HHSDGs in Ghana, opportunities and challenges. And we have a number of institutions that have 15 minutes each to make a presentation. So I want to find out if their representatives are here so that we can start mounting the podium to do the presentation. So the first one is the UNFPA, youth-related issues on SDGs. Please, is the UNFPA rep here? Okay. Oh, thank you. And Ghana Federation of Disability Organizations, is there a rep here? Okay, thank you. And then we have the GAIO. Okay, great. And ARHR. All right. So please. Yes, please. So do you have presentations, PowerPoint presentations or? Okay. So we'll do it in that same order. Unfortunately, I do not have your profile. So please, when you mount the stage, kindly introduce yourself and your organization. And then you have 15 minutes. I'll be strict on the time so that we can finish in good time. So, Madame Della, from the UNFPA. Okay, ladies and gentlemen, please, a round of applause for UNFPA. 15.
All right. So while the technical team is sorting things out, I think we can just start speaking to the presentation. So we'll not dwell so much on the youth-related issues alone, but the work of UNFPA in improving the health SDGs generally, particularly SDG 3.7 on improving maternal health. Yeah, so I'll start, and then my M&E colleague will add a few of the challenges. So we work around achieving what we call 3 transformative results in all UNFPA countries globally. So we are attaining to get to 0 preventable maternal deaths by 2030, 0 unmet need for family planning, and 0 sexual and gender-based violence. So this is a kind of Herculean task. Somebody will ask, is it possible to get to 0? But I think that when your target is a bit ambitious, it kind of propels you to want to do more, achieve more with less resources. So that's what we've tried to do. So in the area of maternal health, getting to 0 preventable maternal health, we work in the area of emergency obstetric and newborn care. We've had assessments that have showed us the percentages of facilities that meet what we call the IMOC signal functions. And the recent report from WHO and the World Bank just last year tells us that we are just at 10% of facilities surveyed who met the basic IMOC functions, and we had just about 13% meeting the comprehensive emergency obstetric and newborn care signals. It tells us there's still a lot more to do. So most of our facilities are partial IMOC compliant. So the way the questions are asked, you may not have one thing that addresses, let's say, bleeding in delivery, but you may have other things, so that it causes you to fall into the partial signal function. So in the area of IMOC, we build capacity of providers in the various IMOC signal functions. We provide equipment for some of the facilities, and then we have supported UNICEF to integrate the perinatal death response systems with the maternal death surveillance system. So we don't have separate maternal death audits and a separate newborn or perinatal death audits, but the 2 systems working together. So we do have a unified policy in place now, and with providers and neonatologists trained in that unified policy. Then we also work in the area of maternal and perinatal death surveillance and response. So we are asking, why did a pregnant woman die? All of these help in our quality assurance and accountability systems. Why did the newborn die? Why did the pregnant woman die? So beyond the reports that come from the facilities, are there any actions being taken to address the various recommendations? You know, Ghanaians, we're good at writing big English, big reports. But beyond that, what are those actions that come out of those reports? So we make sure that the audits are being done, and beyond that, we have task force set in place to make sure that there are follow-on actions to address the recommendations, including recently working with SHRAJ to make sure that the accountability system is kind of taking a top-notch higher. Then we also work in the area of fistula repairs. So it's not just about maternal death, but the maternal morbidities. What are those illnesses also that arise from pregnancy-related issues from delivery? So we work in the area of fistula, and we formed an innovative partnership, multi-sectoral partnership called PERFECT, which is Partnership to End Fistula in Ghana. And we had the former First Lady launch this partnership. She contributed to the fund. We've had private financial institutions like Access Bank, Fidelity Bank, opening their own donation centers in their banks where people are contributing to support fistula repairs. And we think that this is a big innovation for Ghana, you know, to have the private sector involved in raising funds and supporting fistula work. We also had other partners like AT and MTN providing space for bulk messaging to raise awareness, etc. So, all right, so we're almost getting halfway. So the presentation is working now. Yes, so number 1. Yes, we've talked about this one. And then this just tells us who our target audience. Our work is normally directed at adolescents and youth and women. Next. Oh. Okay, so in the area it's about domestic sustainable financing going forward. We can't continue to rely on partners, development partners, because the terrain is very rough and uncertain. You wake up one day, there's no USAID at all, and everybody is shocked. So we need to be prepared and ready through domestic and sustainable financing. And then supply chain. So beyond procuring, we need to ensure that the products move from central level to regions and to service delivery points where the women and the girls need them. So we do a lot of capacity strengthening in the area of logistics, warehousing. We supported governments to renovate a number of regional warehouses, including Bono East, which I went to with Eric last year, which has really been upgraded to almost international levels. They didn't have shelves before, everything was just all over the place. Now everything is kind of in place. They have a separate area for quarantine products, etc. So we work in the area of supply chain, last mile delivery, supporting government to move the products from regions, from central level to regions and to SDP levels. And we've encouraged government systems. Eastern region is one, Ashanti is another, who've used their own internally generated funds to continue the process beyond UNFPA and USAID. So in the area of family planning, we also support the women, the providers actually, to train them to use the products that we bring. So the fact that you're a nurse or you're a doctor doesn't necessarily mean that you can insert, let's say, an IUD. So we provide capacity building sessions for the providers to be able to use and provide the various methods and with methods that we bring in. We also support innovations around new and lesser used methods, like what we call the self-inject. So beyond a nurse giving you an injectable, we've supported the system to be able to have clients, the farmer from that village, trained to be able to inject herself. You know, when her husband will give her a slap, when she does it quietly and nobody is aware. So all of those is helping us to improve and empower women in that regard. So I'll stop there, and then my M&E colleague will add on.
Thank you, Della. I'm not going to, go any deeper because I believe all the challenges and all the situations were already mentioned. But if I may echo some key parts of what were already discussed and mentioned, is the data utilization, as the professor mentioned. So although all data and evidence are increasingly generated, they are not always synthesized, interpreted, and utilized to inform policy and also the programming. So let's just think about how we link between the data and evidence generation and meaningful learning, and also the practical utilization of those data and evidence. And the next one I would like to mention is the complementarity. As Professor mentioned that, think tank, had really great studies and research. But I believe that, those research and studies must be complementary along with the government's national data systems and also the initiatives. So that we don't work in silos. And lastly, again, Professor, sustainability. So let's think about how the government can be more accountable and also be sustainable when it comes to financial situations and also the ownership. Thank you very much.
Okay, so now the PowerPoint is up. I'll just talk a little bit about the youth part of the work. And also, I forgot to mention one thing under maternal health, which the NDPC colleague alluded to. So we have this initiative to have the president lead maternal health advocacy in Ghana. If you recall, during his earlier tenure, he had come up with a an advocacy for all the MPs to make 10% of their salaries to contribute it into a kind of maternal health fund in those times. And then at the recent launch of the VNR report, it again reiterated why we hadn't made progress. So we have contacted the SDG advisor on presidential, on SDGs, presidential advisor on SDGs, who's working with the president to lead this campaign to improve maternal health and make sure that we even get to zero preventable maternal deaths. Even one woman dying in pregnancy is not good enough. So beyond the SDGs target of 70, we are trying to see whether we can get to zero. So that is presidential initiative on maternal emergency rescue. Then we developed another initiative called Timer, which addresses the second delay in reaching care. So after you've decided to go for healthcare delivery, is there transport? Is there the road network good? It talks about all the multi-sectoral partnership, the social determinants of health that the earlier two professors talked about. So the Ministry of Roads and Transport has a role to play in that. Water and sanitation, they all have a role to play in that. The private transport union associations all do have a role to play in that. And since we launched Timer, we've seen an increase in communities that are accessing skill delivery at facilities. So about the youth component of the work in improving the health SDGs, we have what we call the Youth Leadership Fellowship Program, or the YOLE program. We have two of them represented here. Each year we take on about 30 of the young people who've just graduated from various institutions in the school, and we build their capacity to be youth leaders, take active role in decision making, don't sit down for people to decide on their behalf. So they said, for us without us. And then we are also leading various projects in the area of youth security, formulation of policies, and adolescent health policies. And we've supported the Ghana Health Service to kind of renovate and institutionalize the provision of adolescent and youth-friendly services within schools and in facilities. So those are some of the results so far. So these are just accelerators, and we don't have to go over them. Thank you.
Thank you very much, UNFPA. Our next session will be done by Mr. Moses Fodro from the Ghana Federation of Disability Organizations, GFD. With a round of applause, please. Let's welcome Mr. Moses Fodro. Please, those who have slides, kindly get to the technical desk so that we can facilitate the presentations.
All right, so thank you so much. Good afternoon, Madam Chair and audience. Yes, so the Ghana Federation of Disability Organizations is the national umbrella body. We currently have about 13 OPDs, which represents the distinctive impairment groupings that we have in the country. Our membership is on record is around 187,000 across the country. The GFD looks at the SDG and other development indicators from the perspective of vulnerabilities. And I take note of the Prof earlier presentation when you highlighted on lack of disaggregation of data. I think that is quite a significant area that we all need to work towards. But we must commend the Ghana Statistical Service. I think in recent times, they are coming out and with all of us, our inputs, a framework that will enable us to get the data and be able to track. So just to also say that from the perspective of the Federation, we equally have a challenge assessing nationally aggregated data that will enable us to monitor and track. Having said that, there are some core issues that we think that are critical that need to be looked at. The first is the issue of mental health. As a policy, we have a national policy framework, we have the law, but in terms of implementation, one of the critical things with regard to mental health for persons with disabilities has to do with access to medication. Even though the policy and the government's rollout of programs speaks to the need to make it affordable, from our interaction with our members, and by the way, to say that one of our members, the Mental Health Society of Ghana, specializes in dealing with our community who rely on these services. The issue of affordability of the medications and also the availability of same is one of the critical issues that policy makers need to look at. From our interaction and the data we have had across the country, the MMDAs are doing well by integrating this component into their considerations when it comes to disbursement of the District Assembly Common Fund for persons with disabilities. I.e. to say they are allowing our members to be able to access some financial resources, so they'll be able to have their medications. And as we all know, the medications more or less become enabler, because once people are on medication, they are able to integrate very well into the society, even though ultimately the professionals will tell us medication is not really, the solution. But it helps when people take medication, they are able to go about their normal integration into societal issues. So we pay particular attention to that, and to the extent that we don't really have much data to measure this level of access. It's based on some anecdotal studies and focus group discussions we've had with our members that is bringing all of this. The second issue has to do with some specific disability groups with regard to communication. And here I'm talking about people who are deaf. Communication is an issue. From our own coalition and research, the National Association of Deaf are saying their members are having challenges, one, breaking that barrier. It is because their mode of communication with the sign language is not being institutionalized yet as a service within the Ghana Health Service systems. It is now that the Ghana Health Service is now working with all of us as stakeholders to try and get as many sign language interpreters so that we can break that, communication. Madam Chair, just to share a few thoughts. Last year, we had a focus group discussion with some group in the northern region, and they tell us that from their count, which data is what we have not been able to independently verify, they could count not less than 37 of their members who they believe, under the circumstances with which they passed, it was because the communication between the people and the health service providers was not there. And we are talking about people who were pregnant. They died through pregnancy. And so this is quite an issue that we thought that, and we have discussed with Ghana Health Service, that we need to have a study into that area so that it can help all of us understand this. The third one I want to talk about has to do with accessibility in terms of physical environment. Ghana, we had the Disability Act in 2006. We've had some 10 years of moratorium for facilities to be made accessible. We still have issues around physical accessibility in some, facilities across the country. The issue really has to do with old buildings that were providing services, to the public before they come into effect of, the law. Some services are still going on in those facilities. And anytime you do an accessibility audit and you have those discussions, the discussion has been, okay, because this was an existing facility, the owners didn't factor in. But services are still going on in there. So that bit needs to be broken down so that we can all understand that it is not about just expressing sympathy for the group, but it is about a barrier that is not enabling some categories of the population to access services. I think from our perspective, we believe that a lot of sensitization and education has gone on in the country, particularly the Ghana Health Service. In recent times, they have proactively come out with directives to all their branches to say, can you have some directories that will attend to the needs of persons with disabilities? But this remains directives, because from last year, the checks we have done from all our districts shows that the implementation is yet to take effect. What that will do as way of policy is that it breaks the barrier in terms of stigma when people will have the confidence to go forward and seek, health services. Once they understand that if I get to a facility, I have somebody I can, first of all, talk to in confidence who will show me around. That is an enabler that allows a lot of persons with disabilities to go forward in service, delivery access. So, Madam Chair, without wasting much time, I think there are a lot to talk about, but these are the key things that I want to highlight as we all embark on tracking our progress in the health sector. Thank you very much.
And that is Mr. Moses Fodro from the Ghana Federation of Disability Organizations, highlighting disability and health issues. At this point, I would want to invite Mr. Labram Musa to give us to lead us in an energizer before we continue. If you know this man, every Saturday he's on the Bree Mountain and he drags his children along. That's a little bit of child.
Right. Oh my goodness. Did you hear that? Right. So please, can we be upstanding? I won't take my jacket. But please. Right. So we're going to have a very quick energizer. I'm not sure if I heard physical activity in the presentation so far, but I think this is also very critical and very important in the discussion we're having here today. And we need to walk the talk, right? I was wondering the kind of food they even serve us. But anyway, this is something we need to be doing. Organizer, did we invite the hotel to be part of us? Because I think that is so very important. Chief, the hotel, did we invite them to be part of us? Oh, we did. Okay, right. So I think next time we need to invite the hotels to be part of some of such meetings because it has everything to do with them. Right. So let's pick by a very simple one, okay? So we go like this. 1, 2. Okay, so that's the demo, right? Let us go see the okay, so that's the demo, right? So you just flip up and come down and flip down. So we go the reading. We count 10 and then 10 compared to that one, right? We'll go 20. We'll go 1 to 10, 10 to 1. Okay? So can we start now? 1. Count with me. 2. Let's go. 3. All of us. 4. Okay. 7. 8. 9. 10. Let's go. 10. 10. 9. 8. Good. 5. 4. 3. 2. And 1. And 1. Okay, great, great, great. Over now, so. Now, so one more. So, we're going to check those who have good stamina, right? Well, those who have good balance, right? So, it's going to one day. Oh, so just, the project like this, right? Yes. If you have a high here, you can get dropping then. Like, just like how count 10 and then we change and then that's let's go. Oh my God. Let's do what is. Let's go through 4. Let's see. Let's go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Let's go 10. Let's go about 10, 9, 8, 7, 5, 4, 3, 2, and 1. Let's do the next. Ready? Let's go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10, 8, 6, 5, 4, and 1.
The jacket was not compulsory until the exercises started, and we knew that the jacket was either an obstruction or contributing to the heat that was being generated. Thank you very much, Mr. Labrown. I will move on to Gaio, and I would want to call on Miss Margaret Imprim to give us a 15 minutes presentation. I'll be at the back there signaling you 5 minutes more and all that. Thank you very much. Please, a round of applause for her.
Thank you very much. I'm still panting, so I don't work out. But that was an energizer. Right. Good afternoon, everybody. My name is Margaret Imprim. I am with Green Africa Youth Organization as the coordinator for our Youth Climate Council's Global Alliance. And I'll be talking more about the progress towards our achievement of the HHSDGs, particularly looking at the climate change and the health perspective. I have my slides, so I don't know if it will be shown or I can just go ahead to speak to it. Yeah, I sent it via email to Gladys. So I'm hoping it's, otherwise I'll just go ahead and speak to it here. That's okay. All right, great. So to just start with, we've had a lot of conversations on climate change, and thank you so much, our first professor, for speaking a lot about the relationship between health and a lot of things, including climate change. So as we know, climate change is one of the biggest threats to our public health, particularly in Ghana, and this is Ghana context, so I'm going to focus more on Ghana. And as you know, majorly health outcomes are shaped by environmental and climate factors, which we'll look into it. So basically, what Gaio will do is we work at the intersection of climate action, youth leadership, and community resilience, including their health. So a bit about us. Gaio, and I have 2 of my colleagues here as Executive Director. Richard, if you could just wave for us. and also lead for our Just Transition. If I could just wave. So as you can see, we are all youth. So it's a youth-led civil society organization, and our focus areas are in zero waste cities, also in adaptation and resilience, also in just transition and green jobs for youth. Basically, what we do is, aside from engaging with youth, we also have strong community engagement, aside youth, also in vulnerable populations. And what we do is translating climate evidence into community level action and policy advocacy. So we influence, we co-create, and we implement and empower, all for the purpose of ensuring that there is climate resilience everywhere we go. So why does climate change and health matter? Why does this conversation matter? As we know, climate change affects health directly and indirectly. As we know, SDG 3 being good health and well-being, it's having interrelationships with SDG 13, that's climate action, SDG 6, clean water, SDG 2, zero hunger. And all of these things are linked with climate-related health risk, which of course threaten progress on the health and health-related SDGs that we want to achieve. A bit about the health impacts in Ghana. As we know, we are in a tropical environment, a tropical region. So the rising temperatures definitely will bring more heat stress and heat-related illnesses. Changing rainfall patterns everywhere we go will bring in flooding, will bring in water contamination, will bring in cholera outbreaks. Also, the climate variability also bringing a lot of vector-borne diseases. And also air pollution, we have a lot of cars around, of course, having a lot of carbon monoxide being produced, increase, of course, in the greenhouse gas emissions. That is definitely adding to the items that influence climate change. Also bringing in air pollution and environmental degradation, causing respiratory diseases. Also climate shocks, a lot of mental health stress, because we are not ready for whatever is happening. There's also food insecurity, because at some points farmers are expecting rain, they get harmattan. Times when they're expecting harmattan, they are getting rain. The populations that are most affected are urban poor and informal settlement residents, basically because of where they are situated, the slum areas. Also, our elderly persons, they don't have the strength to withstand some of these climate shocks. Children and pregnant women, rural and coastal communities, because they are mostly very close to the sea or very close to areas that are heavily hit by climate impact, and also youth that are facing climate-induced livelihood disruptions. So they'll have to leave their homes to other places in order to have better livelihoods. Progress so far in Ghana, the National Climate Change Policy has a lot of health sector involvement, and as we've had a number of the conversations here talking more about what Ghana has been doing, this think tank has really brought a lot of focus on what Ghana is doing, ensuring that we place more focus on health and health-related SDGs and what we can do to bring things to pass. Also, there's a lot of integration of climate consideration in our public health discussions. Now, the climate conversations are not left as abstract, but they're definitely included in public health discussions. Also, there are early warning systems for floods and disease outbreaks. There is the growing multi-sectoral collaboration, as we see here. And there is the increased youth and civil society engagement, as you see all of us here. Now, GAIO's contribution to climate and health. What we do at GAIO is we increase our community climate education and awareness on health risks, particularly in areas in the Upper East, where we have conversations on all these things because they are heavily impacted. And also we have youth-led advocacy initiatives on climate-responsive health policies, and also through our GAIO Eco Club chapters in the tertiary institutions, we work to make them climate ambassadors so they too can also contribute in the conversation. Also, we engage with policy platforms and we amplify these youth voices in climate and health decision making. Challenges, as we know, for whatever is going on here, limiting limited financing. Once our coordinator was speaking, he mentioned that we need to get a sustainable plan. Where there is no finance, what do we do? Does it stop? We need to find ways to have more finance. Also, gaps in the climate, linking climate indicators to health outcomes, with weak coordination between sectors at the implementation level, and also limited awareness and climate impact that is advancing faster than policy responses. We have lots of policies coming up, but because the execution sometimes is a bit slow or doesn't get as much as we want, we are usually at a shock. What we can do as multi-sectoral think tanks, of course, the evidence-based policy guidance, coordinating our conversations, monitoring progress on HHSDGs, supporting advocacy and accountability, and creating space for youth and civil society to all participate. Recommendations. The first recommendation is to strengthen our climate health policy integration and not separating these conversations. Also, to invest in preventive and community level health adaptation and prioritize vulnerable populations in climate planning. We don't have to focus only on the urban communities, but all vulnerable populations. Also support youth-led climate and health initiatives, because the youth are made of the major population here in Ghana and even Africa and beyond, and making sure that they too are very passionate as we all are. We also have innovative ideas, so including youth in these initiatives and in these solutions, and sustaining multi-sectoral collaboration beyond these workshops. So ensuring that we are having a lot of collaboration, different sectors coming together to see how best they can work together to bridge all gaps and to also look at all the overlaps that might come in. In conclusion, climate change is not just an environmental issue, it is a health issue, and Gaia remains committed to supporting Ghana's progress through youth-led action, advocacy, and partnerships. And in achieving our HHSDGs, we require climate-responsive health systems, amongst every other thing. Thank you very much.
Beautifully delivered, Ms. Imprim. Thank you very much for linking us on the SDG journeys with climate action and youth involvement, highlighting peculiar challenges within the northern sector as well. We will move on to do our final presentation for this session, and I would want to invite Nananya Kukunedu from Alliance for Reproductive Health Rights to give us this presentation, also 15 minutes.
Hey, good afternoon. Okay, so this afternoon, I'll be presenting on the progress towards the achievement of health and health-related SDGs in Ghana, but our focus is on the opportunities and challenges in gender and reproductive health rights indicators. I will speak briefly for the sake of time on key reproductive health and gender targets, and also the progress so far, the key challenges we identified, opportunities, and some recommendations. So Ghana made notable progress under the MDGs, and especially when it came to issues of poverty reduction and access to basic education. However, by the end of the MDGs, we were not able to fully achieve several critical health and gender-related MDG targets with maternal health, reproductive health, and gender equality. So these unfinished priorities inform the transition to the SDGs, which expanded the global agenda to emphasize equity, rights, quality of care, and sustainability. So since Ghana's adoption of the SDGs, we've been able to align some of our major national development strategies with SDG 3, which is on good health and well-being, and SDG 5, which is on gender equality. And the main goal is to be able to fill in the gaps we were not able to achieve under the MDGs. At the end of the MDGs, maternal mortality remained high. There was persistent unmet need for family planning. There was limited access to sexual and reproductive health services, especially for our adolescents. Then gender inequalities in decision-making and access to resources. There was also significant rural, urban, and socio-economic disparities in our health outcomes. So by 2030, Ghana has key reproductive health and gender targets we hope to achieve. Under reproductive health, our goal is to reduce maternal mortality to fewer than 70 per 100,000 live births, achieve universal access to sexual and reproductive health services, increase modern contraceptive prevalence, and unmet need for family planning. We also aim to ensure skilled attendance at all births, expand adolescent-friendly sexual and reproductive health services, and finally, fully integrate our SRH services into the universal health coverage. On gender equality, the target is to eliminate child marriage, gender-based violence, and harmful practices, increase women's participation in leadership, strengthen legal enforcement of women's rights, and improve education and economic of women and girls. So for the sake of this meeting, we looked at the SDG 3.1, which is on maternal mortality. And one key indicator used to measure or track maternal mortality is the indicator 3.11, which is the maternal mortality ratio. It is the number of maternal deaths per 100,000 live births. And as you can see, the global target is 70 per 100,000 live births. And as at 2021, we are 301 per 100,000 live births. That's about 4.3 times the global SDG target. And though this is an improvement, considering where we started from, the pace at which the reduction is happening is very insufficient if we want to meet the international and the national targets by 2030. Also, despite the national progress, there are some rural-urban disparities. For instance, maternal mortality ratio in the urban areas decreased from 271 to 233 in 2021, but for the rural areas, they rather increased from 364 to 374. Also, there has been a consistent maternal mortality rate in the north. That's the northern region, upper east, and the upper west regions. A key indicator under the maternal mortality is skilled birth attendance, and that's the percentage of births attended by skilled health personnel. So the percentage seems to be increasing if you look at the chart. From 98 through to 2022, we've done, I think, a tremendous work from 43% in 93 to 88 in 2022. The share of birth attendance by traditional attendance too has really increased from 16% to 7%. And also, almost all women receive antenatal care from skilled birth deliveries. SDG 3.7 is on reproductive health access, and the target is to ensure universal access to sexual and reproductive health rights services. And the SDG 3.7, a key indicator is the demand for family planning satisfied with modern methods. And the total demand for family planning that is satisfied with modern methods is 47% among married women and 52% among sexually active but unmarried women. So nearly half of married women in Ghana are still not satisfied with the modern family planning methods. Closely linked to that indicator is the modern contraceptive prevalence rate. And though it's not an SDG indicator, it's used to track the SDG 3.7. With that, from the charts, 10 point, there has also been an increase from 10.1% to 28%, though it's not really enough because less than 1/3 of married women currently use modern contraception. So there is more room for improvement. Still on SDG 3.7, adolescent birth rate is also an indicator used to track. And under that, we can see progress so far. But aside the progress, there is this interregional disparities with high rate of 26% of young women in Savannah region getting pregnant compared to those in Accra having about 6%. So despite the national gross increase or reduction, there is still interregional disparities that we have to focus on. SDG 5.3 and 5.6 focus on abolishing some of these bad, harmful practices such as child marriage. And from the GSS multiple indicator cluster survey, 1 in every 5 women aged 20 to 24 years was married before age 18. Though this data is old, but that's the recent national representative data that we could get. And with that too, there is more issue of regional disparities. So from our findings, we realize maternal mortality is so high above the global target. There is also inadequate financing, as we've been discussing so far. There is high unmet need for family planning, and there is also sociocultural barriers limiting or affecting how these norms can be changed. We also identified key opportunities that we can leverage on to reach SDG 3.3 and 5 by 2030. Under SDG 3.1, we can leverage on the expansion of our CHIP compounds. Under 3.7, we can integrate our SRH into primary healthcare and UHC. Under 5.3, we can leverage on community-based advocacy and social norm change programs. Under 5.6, we can also leverage on the rising female participation in leadership and civic engagement. We have, I think, a lot of recommendations, but the key ones that we have been doing as an organization is scaling up community education and male engagement to shift harmful norms. And that is what ARHR have been doing for the past few years. You can read about it on our website. It's Co-Impact Project, and this is one thing we've been doing for some time now. We can also strengthen partnership between the government, civil society, and donors to build gains with a focus on equity. We can also promote girls' education and empowerment and strengthen policies to keep them in school. So personally, I think we should look back on the Adolescent Mothers Re-Entry Program. Though the policy exists, its implementation has not been really effective. Then lastly, invest in adolescent-friendly SRH services, particularly in the rural areas. Thank you.
Thank you very much, Nananya Kukunedu. She bears my name, so I mention it with pride. Okay, we are grateful, but I was particularly interested in what the man and woman were doing there. What were they doing?
We have been preaching about inequalities, and just 1 minute. So Ghana has transitioned, and we've done a lot when it comes to providing health infrastructure. But our work indicates that there can be a facility in a community, but the woman will still not go to the facility or access the facility if the man does not give approval. So it was an intervention that we undertook, and it's working very well. So we don't have funding to continue.
Thank you very much for that brief explanation. The role of men in reducing maternal mortality, accessing health, maternal health services, and family planning and other reproductive health services is very important to us in this country. So please let us go on with the advocacy. Don't let us stop. They say that their funding is finished, but the principle still remains that if the man is involved, we don't really need a project to get a man involved. Everybody here can be an advocate so that men are involved. If your wife dies, it is very painful if she leaves you behind with 4 children. Mr. Labram Musa, you have your turn here on the podium to discuss with us discussions on collaborative pathways to action. Ladies and gentlemen, Mr. Labram Masawudu Musa is an ardent, astute civil society activist on non-communicable diseases. One of his works that I admire the most was to challenge, support the FDA to bring some sanity into our advertising spaces where media and public figures are not allowed to advertise certain products on our market. Beyond NCD's tobacco intervention, bringing to the SSB tax implementation in Ghana, this young man here has been at the forefront of all of it all, and he's a proud member of the think tank. Shall we, with a round of applause, welcome Mr. Labram Musa.
Right. Thank you very much for those kind words. I think this is the moment, right? But you see, I always feel like, when people sit down for far too long, it becomes a problem. And you know what? Those who have been standing here are benefiting from healthiness than those of us who have been sitting for far too long. So please, and once in a while, just take a stroll and come back, because we are told that sitting is the next tobacco. And you know what tobacco does to the human body. It's the most devastating, product that mankind has produced on earth. So if they relate sitting to tobacco, it tells you, the effect that will have when we sit for too long. So please, sometimes be upstanding and then, and then sit down. Okay. Right. So this is the moment. I think this moment is very, very important. For a think tank where we feel that there is a need, for us to also contribute our small quota, to what the great team or the think tank has already achieved. In some few months or how many years? Yes, 2 years, yes. And then we are here again, to continue with the work. So on that note, let me say that my work here is basically to also hear from you as experts. I think we are tired of the long talks, right? So we've heard from Prof. Bhutta, from all the profs, and then the other speakers here. So this is the time for you to also add your voice on the subject, the topic that has been given to us. If you look at the agenda, so we are here to discuss collaborative pathways. The point is that how do we ensure that we move from point A to point Z? I won't say to point B, I'll say to point Z, because we have to accelerate action in whatever that we do. And the fact that we also have to move away from the siloed mentality of working, because I think that came strongly in Prof. Bhutta's presentation, where he mentioned the fact that one of the key achievements of the MDGs were the fact that we work together. So how do we collaboratively work together to ensure that we achieve, the health and health-related SDGs? So on that note, I'll open the floor, and so you can just raise up your hand. It's about, if you have a question, a burning question you want to put to all the presenters, you are free to do so. Otherwise, any recommendation that you have. But if you also have a question, we don't expect what you just ask a question, but try to give us more of solutions, because we want solutions to drive the world now. Don't just put a question, but try and have some recommendations, some solutions to the work that we all seek to do together. So if the mics are ready, I think there's a first hand here. How many mics do you have around? Well, are the note takers ready to help us to pick the points? I think they are ready, right? Are the note takers ready?
Yeah, so thank you very much. My name is.
If our note takers are ready to start picking, the points, because we cherish them a lot. Right, so Solomon.
Yeah, thank you. I'm Solomon, fully from the NCD Alliance Ghana and Vast Ghana, and that's my boss. My first question goes to Professor Frederick Armah. During your welcome statement, it was very insightful. I was inspired by that. You noted that the development gap is narrowing, but it's still open. So my question basically is, what population groups in Ghana are still behind when it comes to the SDGs, progress? And how can policy deliberately and meaningfully, I'm choosing my words very carefully, deliberately and meaningfully involve such groups, to ensure that we don't only rely on national average, but everybody is involved. And then my second question goes to Prof. Bhutta, where you spoke about, Prof, I hope you can hear me. All right, thank you. The current setback from our donor partners. So I would want to know, how do we strengthen domestic, ownership and financing of the SDGs without inequities or overburdening the citizens? I'm asking this question because I work with the grassroots a lot, and we all know the risk factors to the non-communicable diseases: the tobacco use, alcohol, physical inactivity, unhealthy diet. There is one big challenge which has to do with the industry. We know those who are producing these products, but we are unable to fight them or have a strong, stance as a nation against these entities. What is your take on the work of industry compared to public health? Are we supposed to give them a space in the development agenda, or we should sideline them? Thank you very much.
So your second question, repeat your second question for me.
All right, so basically my question has to do with,
the
second one. How can policy deliberately and meaningfully recenter them rather than relying on, national average? I'm speaking in terms of those who have been left behind. Thank you.
Yes, thank you very much. If we can make our questions very brief, so at least others can also have the opportunity. Just so, Prof, if you can take so please just respond so we can be more interactive. Yes.
Thank you very much, Solomon, for the question. Very insightful question. The first one relates to what population subgroups are behind, and then the second one relates to what kind of policy interventions can we enact or implement to make sure that we bring those who are peripheral to the discussion to the center. Now, so if we want to see, and fortunately, a number of presenters have highlighted some population subgroups that are behind. But I'm looking at a much more conceptual way of identifying those groups. Now, we talked about averages. So if we take, for instance, contextual factors, and here I mean by geographical region. In Ghana, we talk about urban areas, rural areas. We see large disparities between the two groups in terms of accessibility of services, affordability of services, and availability of services. So if you use urbanicity, rural-urban divide as a discriminant, you see this is clear. Affordability, accessibility, availability. There's a lot of heterogeneities relating to that. So in terms of accessibility, affordability, availability, rural areas are much more disadvantaged than urban areas. And even those in urban areas, we have the urban peripheral groups, what we talk about marginal migrant populations who are internally displaced and do not have access to some of these services. So I'm looking at it from a conceptual point of view, how we systematically identify these groups. That is from the contextual part. Then we can also look at the biosocial. So biosocial, three key factors. Age. So it means that age groups, we can see disparities among the age groups. People who are in the reproductive age, those who are outside it and all of that. For instance, the elderly, in terms of climate change, the impact of climate change on health, the elderly, those who are disadvantaged in many ways in terms of physical disability. We see them in that particular cohort. So this is age. Another factor about that is also about gender. It's also a biosocial factor. We also see a lot of gender disparities when it comes to that. So that is a very important thing to note. So we can use some of these conceptual factors to be able to distill where the gaps are, because we see that this is not uniform across board. Biosocial factors, contextual factors, and then even in terms of sociocultural factors, in terms of income groups, social groups, there are also a lot of disparities that are there. So we can look at a number of population subgroups using these discriminants to identify where the gaps are and what interventions need to follow from there. Then, what is logically consequential from this identification is the need to enact policies that resonate with the population subgroup of interest.
Yes, Prof, if you can wrap up, yes. Thank you.
Yeah, we talk for a living.
No, probably can, yes.
So then we are looking at one key issue is disaggregation of data. Disaggregation of data. So how do we disaggregate the data to take into account and all of these groups and their peculiar needs? And that is the policies that we should be trying to implement. Policies that focus on disaggregated data that tailor the responses to the population subgroups. Thank you.
Thank you very much, Prof. So, yeah, please, we have Prof. Bhutta to respond to briefly, Prof.
So, two separate but linked questions, and I'll answer them succinctly. Financing, how are we going to afford, funding SDGs or progress in the current global reality? I mean, the answer to that is it's not going to be easy, but it will require domestic financing. It will require countries standing on their feet, increasing allocation for social sectors and health, more from their current levels to higher levels, and then choices will have to be made. But across the 181 low and middle income countries that we have studied, there is capacity in middle income countries to do this. And in low and middle income countries, capacity to do this in about 60 to 70% of countries, provided they reduced expenditures on government, on lavish spending, and on defense. Those three things are common factors across many countries. So if governments don't spend more than 1, 2, 3% on health, on social sectors, respectively, it's not because there isn't money in the coffers. It's because money is spent on many things, including, you would be surprised to note, how in many poor countries also on private planes and on fleets of luxury cars. So this is very much a governance issue. It's very much a political ownership issue. And there are lots of examples of where countries have done it. So that's one specific answer. Now, the second relates to the question of industry. So, it is problematic to paint the entire private sector and industry as the evil enemy. There is no progress that can be made without including and engaging with the private sector. You can't make vaccines in your backyard. You have to have engagement with the industry. Similarly, for lots of nutrition commodities that we use for many children in humanitarian settings, the ready-to-use therapeutic foods, you have to work with the industry, local industry as well as global industry. Now, the question really is an engagement with the industry in terms of rules of business and also ensuring that the balance of their profit making is not adding to the costs down the road in terms of waste and also in terms of sustainability, food environment, and the like. And in many countries, that's a negotiation that is possible. In Southeast Asia, for example, people are able to work on a code of conduct with the Nestlés of the world to say, you will not do this, and you will do what is appropriate within certain parameters. Same with the pharma industry. You're able to regulate prices, also move slowly towards generics. So why should it be South Africa only leading the world in terms of generics and licensing? Every country can do this. So there are examples of how this can be done. And now I will say one thing which probably many people might misunderstand. Some of this de-development and, let's say, moving away from development assistance by high-income countries and high-income countries, including big pharma, is also an opportunity for low and middle-income countries to develop their own capacities. We have often said Africa does not have strong vaccine manufacturers, does not have a strong, amazing as to how it does not have a strong pharma sector in big geographies like East Africa. This is your opportunity. If people will not give you largesse and, let's say, development financing, go ahead and develop your own. I mean, there is nothing like a free lunch anymore. So you can make your lunch more affordable.
Prof, thank you so much for the response. Yes, so please.
Yeah, okay. My name is...
if you can make our responses very brief too, that will help us.
Yes, I want to know how we are going to share all the good things that we have seen today to the one on the streets. And then two, how do you also ensure that we have a kind of ownership of, I think he asked, where is the data? How do we ensure that we own it, or and therefore we can use it as and when we need it?
Thank you. Do you have some solutions to what you have said? Some idea on how you think we can?
I asked this based on what we have heard. I mean, about LIMS and other health data being taken over, and all the years, the effort that we have made. Where is our data? Thank you.
Thank you so much. Yes, so the think tank members will respond, but I go to
thank you very much for the presentations. Mine is more of a suggestion. We've all been told that the progress that we have made over the years is very modest. Some statistics have been quoted. Mm-hmm. And I want us to reflect on our thinking, how we see progress, and how to exert accountability, for example, for our leaders. How can we shift from our discussions, seeing development only in terms of reducing, let's say, inflation, increasing GDP, and those economic indicators, and hold people accountable for how many deaths, maternal deaths, were you able to reduce within your period? How many car accidents were you able to reduce? The environmental consequences of our actions. You see, it will shift our discourse to just a few things, and people achieve just maybe one or two economic indicators, and the whole country feels that, oh, we have reached there. But at what cost? A woman died because very small thing happened. We've lost that person. The cost of the death of the woman is not, nobody really calculates that. So maybe in going forward, we may also have to shift that mentality. Another point is dwelling more on the efforts that we are making rather than the results. In a lot of the presentation, what I realized was, oh, we are doing this, we will do this and that and that. But what we did, or what we've been able to do, what has it resulted it into? Right. And we should be able to challenge people to bring more results rather than efforts that are being made. Thank you.
Thank you so much for those recommendations. I think they are well noted, and I think they are also very good suggestions. Right. So we move to the table. Can you mention your name and then you can take the floor?
Vaida Yakon. Mine is a comment and a suggestion. And this has to do with the presentation on disability. We talked about sign language. For some time now, on the part of education, nursing and midwifery, curriculum has been revised and sign language is taught. Introductory sign language is taught so that at least nurses and midwives can communicate with clients, health education, or whatever that matters. Then, on the part of regulation, I was wondering if it should also become something that facilities, before they can be accredited by the Health Facility Regulation Agency, they ensure that they have this component that clients can benefit. So regulation aspect, maybe that could be pushed through.
Right, so thank you very much. Do you want to respond to, yes, so Prof will respond to some few.
Yeah, I think a number of them are comments, but the issue about how do we get this information to the ordinary person on the street, I'll say through you and through me and through all of us. We work in various spaces and in various at various levels, and we can carry these things along. We hearing very nice comments like, "Don't clap for your MP because he has provided some whatever," but ask him how has it contributed, how has it helped the district's health administration in reducing the maternal mortality in that area, and so on and so forth. So we have had very interesting comments here, and we can all be agents of change. We carry them along in our very, very small ways, and then it can spread all over. And we will share all of these things with participants and see how we can carry them forward. Then the issue about data, very, very important. I had a question, and I think the moderator is right, asking us to think through solutions that may be coming out of our questions. And I am going to ask Ghana Statistical Service, how can we work together? You've been doing a lot. We appreciate the great work you have been doing. But we know what Prof. Bhutta has said, and that is right. If you look at the data that has been presented by all organizations, most of them, the major source is DHS. So if tomorrow we don't have, and I have used DHS so much in my publications and in my advocacy issues. So if in the next couple of years we don't have them, we know you have been at the forefront in collecting the DHS data, but homegrown solution, what are you doing to be able to continue? Do you have a line in your budget if something happens tomorrow, or you are still waiting for somebody else to come, and so on and so forth? So how do we continue with that? And even with the little data you have, even our own census data or national data, how can we work together? I'm not saying how you're going to make it. How can we work together to make them available and usable to inform policy and intervention? So these are my comments.
Yeah, thank you. So probably want to give us a quick response, then we move to you, right? Okay.
Thank you very much, Prof, for your question. My name is Vitus. I work with Ghana Statistical Service. So with our data, I'll say all our data on our website. If you go to our website, for the past 5 years, there are a lot of publications there covering various sectors. Aside the census, we've done a lot of other surveys. So we have data there. But the other thing I think as a country is that let's begin to think of moving away from surveys and census data to what? Administrative data. That's the way to go. That is the best way. Because these surveys and censuses are done within some years interval. When we're preparing the Ghana VNR.
Yeah. Before you continue, can you explain what you mean by administrative data?
Administrative data are data from administrative records, such as institutions. Very good. So the other thing Ghana Statistical Service is trying to do, we're trying to have an MOU with all MDs. With all MDs, once you're an MDA in Ghana, we'll sign an MOU with you, such that your data will be shared, right? So that GSS can have access to your data, and you can also have access to GSS data. So currently that project is ongoing. We are almost through, and very soon we'll be signing that MOU to ensuring that data from other sectors are easily obtainable. That is what we want to do so that this issue of data, will be resolved. Because if you look at the surveys, 5 years, you report on maternal mortality. The following year, you can't use that data again, right? Especially with the VNR. Census is 10 years. You've reported on sanitation. Can you use that same data the following year to report on the same SDG indicator? That is where the gaps comes in. So that is why I'm saying the best way to go as a country is to strengthen our administrative. So we are hoping and praying that if this MOU is finally signed, this issue about data will be resolved. People are keeping data, but they don't want to share. You go to Ghana Health Service, you want data from the ADIMS. We went to Copenhagen, we came back, we had to come out with a health report from DIMS. As I speak now, I went there last year somewhere around September, up to now. We came back, getting data was a challenge because we don't have an MOU with them. And they'll tell you, you don't have an MOU. How do we? So finally, but the top people were able to arrange, we got some data, and the data to have issues. Wow. Gaps, quality issues. So, but the best way, so let's, as a country, let's begin to think of strengthening our administrative. That's the only way that will help us out.
Thank you so much for this information.
I have a colleague here,
who wants to add on, right? Briefly, madam.
Yeah, so he said it all that the alternative for us to go by is the administrative data. And for DHS, it's not being sponsored by Ghana government or Ghanaians. It's an international thing. So if DHS is not coming back to Ghana, then the Ghana government should find some funds for us to conduct it. Other than that, the only way we can go is the administrative data, or when we get some kind of support, international support, then we can sip it into the budget that we have. But as we say, we don't have any budget for DHS. Then concerning that, we're working together. You know, anytime we try to conduct a survey or we're about to conduct a survey, we organize some we call stakeholders engagement for other institutions to come on board. The census we did, we have Energy Commission coming on board because they wanted to have the energy mix that is being used at the household level. We also have the Ministry of Sanitation coming on board to bring in some questions on the sanitations and disposal of waste and among other things. We also conducted a survey last year, yes. We invited Forestry Commission and that to come and make inputs into the information, because at the end of the day, we get the graded kind of information so that if the survey is not conducted on regular basis, we can use it for projections, other extrapolations to move on until maybe God makes a way for us to get more funds to conduct another survey.
God makes a way. In fact,
thank you, Renova.
I feel a bit disturbed, from the information coming here that even, intergovernment, you are unable to access data. Can you imagine what will happen to researchers who on daily basis are looking for information from the health sector or from any sector to buttress what they do? And I think this is a huge challenge. Not having a budget line for research from government of Ghana is I think it's something that we need to advocate, for support them so that the government can, adequately fund them, because research is everything. And we are seeing without the data, we can't do anything. Right, madam, you can take the floor.
Good morning or good afternoon. My name is Edwina. So maybe my is there a concern or a question will be a bit biased because of my background, mental health. So in all the presentations in relation to maternal mortality, I really didn't see, maybe I missed it, where mental health was highlighted. So in my head, was there a research or was there a finding on mental health, how it contributed to maternal mortality? Because even when you read, it tells you that 9% of mental health conditions contribute to maternal mortality rates. For instance, the mother committing suicide or even killing the baby in the first few months after delivery, how that care goes on. So I'm particularly interested in that. And I think that the think tanks can work with the Mental Health Authority to get experts to maybe integrate some of these questions into the community, and let's find out what is happening with their mental health status, the woman's mental health status. As you said, there are some communities where the men don't go with the women. How does it affect them? What is happening in their homes? It may not be that the medical situation is not ideal. It may be ideal, but if things in the home are not ideal, it can actually affect the whole process. Thank you very much.
Thank you so much. So I go to Ampoma, and then I see. Do you want to respond to some of the questions that have come? Yes. So Ampoma, from there, then Prof will just respond. Then we'll move to
right.
This table. Then we'll come there.
Thank you very much. My name is Ampoma, as Labram rightly said. Mine is about the low adoption of contraception. And I want to understand why is there a very low adoption of contraception. Do we see contraception as a cultural barrier or an economic sense? And also I would like to get some clarity as to when it comes to contraception, there are some choice of contraception that also prevent some diseases, especially when it comes to the use of condoms and what have you. And so if we can go deep into the rationale, the reasons why contraception is very low, maybe it will help in some advocacy to boost the adoption of contraception. So maybe a comment as to why the adoption is low. Is it a cultural barrier or an economic sense? Thank you.
Thank you. And please, can you introduce yourself again? Because some are saying...
My name is Ampoma Isaac, the Vice Chair of the Coalition of NGOs in Health, Greater Accra Branch, and the CEO of Concern Health Education Project. Should I continue?
Yeah, thank you. Thank you so much, Ampoma. So, Prof, will you take... So the mental health was taking that one, sorry. There's a comment on the mental health and also on contraceptives. I don't know whether...
So we try and comment on. So mental health was very much a part of these country case studies. So every country case study had an element of looking at not just mental health in the context of maternal mortality, but also, remember, we were also looking at climate change, environment change, and mental health as a neglected issue or what was being done. So maybe David, you could, or Fred, you could talk about that. The second is, we all know amongst the larger determinants, population, family planning, major issue in many parts of Africa. This is now the only continent where the growth rate is going to outstrip resources much faster than many other parts of the world. And that's one of the reasons why there is a separate study that's just concluded that I'll refer you to, which is looking at exemplars of family planning, particularly on African examples. And you will find that there's a lot of homology between what I talked about, social determinants, focusing on inequities, access, gender empowerment, education, and access to family planning tools. I mean, family planning has been impacted by development assistance withdrawal, but it also has created opportunities for countries to invest themselves on technology and tools that have been hitherto supplied for free. The last point is on, really speaking, the challenge of data. Now, the challenge is real. Demographic and health surveys were the only surveys done in a standardized format with quality control, using sample sizes that were appropriate for national or subnational assessments over the last several decades, starting from the 80s, actually. And that became the standard tool for use by global agencies because they could stand behind the methodology and what Macro International and USAID provided, right? In many countries, countries did take ownership of the demographic and health surveys and call those national surveys using the same methodology. For example, Peru, for the last several decades, has done annual demographic and health surveys using the same methodology with a substantial part of their own funds. India does this every few years. They call it the National Family Health Survey, but these are, done with the same methodology. Now, the problem is they're all expensive. And unless big economies or middle-income countries, low middle-income countries are able to put aside resources, this is going to be a big sink in terms of what it costs. I can tell you for a modest demographic and health survey, the cost can be anywhere between $5 to $7 million every time.
the Ministry of Health, Ghana Health Service, and its agencies have introduced. Across the Sub-African region, at least our data is somehow praised. When you go around and you present your data, Ghana is praised for the data that we have. Now, if you look at, NDPC is here, Statistical Service is here, there is no indicator that comes to help that we cannot get data for it. And we know where the challenge is. When we talk about the quality of data issues, the challenge we have is the people that report about this data. Earlier, we were looking at more of summary data, which we're working with the DHIS, but we introduced transactional information systems, where my brother talked about the concern where we get to a point and we are shifting away. But I'm happy to mention that, we have backups of all those data sets. Where we want stakeholders to help us is the people that collect this data for us. They don't see the data as part of them. For instance, if you go, we have a lot of data loss. When you report, for instance, this maternal death issues, or even like neonatal mortalities, there are a lot of data loss that our people are providing services that are not capturing it because they feel it's not an area that they should be doing. So we have been advocating that let's train our people, the people at the very community levels who are collecting this data.
Thank you.
If not, if you look at the national level, a GSS, a Ghana Statistical Service will tell you that everything that comes in looks good, but the quality everybody is talking about is what we're doing. So if stakeholders can support us, we invest on the people that are bringing up this data, then I think we can address the concern. Another angle about our data where we sometimes feel is incomplete is that at the ministry's Ghana Health Service level, we are dealing with both private and government institutions, but we may not have all private facilities reporting to the Ghana Health Service or the Ministry of Health.
Thank you very much.
These are administrative issues that we can deal with at our level.
Thank you.
So I think maybe going forward,
thank you.
The investment in training our people.
Yes, well noted. Thank you so much.
Our stakeholders to help us.
Yes, so we go here. See, if you talk to then others not get the opportunity. So we have to just.
I have not spoken. This is my first time speaking.
Right. Thank you.
The high mortality rate there. If you speak to some of the health professionals there, it's also affects women and their nutrition.
On the data issue, I think the gentleman here spoke a lot about it. I think we have a lot of existing platforms that we should leverage on instead of looking at creating other parallel platforms. So we should, how do you call it, institutionalize the way we are collecting the data so that we are tying the data to people's responsibility so that we can easily know where and who to get this data from. And in doing that, this data will not end with a project ending. It will actually be institutionalized, and that's a sustainable way we can look at collecting the administrative data.
Right. So thank you very much, all of you. Can we give ourselves a round of applause? I think we've all done well. I think on this note, I would just hand over the mic to moderator to continue. Thank you so much.
It's a good round of applause for Mr. Labram Masawudu Musa. Thank you, Labram. Oh, please, our applause is sleeping. Okay. Thank you very much. Just a quick appreciation. Miss Linda Kofi, are you here? Acknowledge your presence. Dr. Yamankwatha, acknowledge your presence. Mr. Isaac Tando, are you here? Okay, acknowledge your presence. I see Miss Akosia Beko. If I do not add your actual title, it's because it was written without a title. So I use the male-female balance there. Then Professor Peter AJ Bafo, are you? Yeah, acknowledge your presence. Dr. Mrs. Ruth Owuswenchi. Thank you for coming. Miss Jessica Adote. Are you here? Thank you for coming. And then colleagues from NDPC. How many team members from NDPC are here? Okay. Thank you very much, NDPC, for your support. And then Dr. Mami Abadazi, Deputy CEO, I've seen you seated through the process. Thank you. And then Ms. Ruth Asantua Kisi from Ministry of Health. Okay. Thank you very much. Please, if I have not acknowledged you, kindly give me a wave so that we acknowledge you. Okay, everybody acknowledged. I'm acknowledging myself too. So our ARHR, there was a burning question, something that interests me on fertility and taking contraception and infertility. Is that something that your research has brought to the fore? 1 minute, please.
So the answer is no. Contraception doesn't lead to infertility. And Prof and other people are here. I think we can all check. There hasn't been any study indicating that contraception leads to infertility. What it does is that some of the methods may delay return to fertility. Yeah, so maybe some people may take the return to fertility to mean that they are infertile, but that doesn't mean that you are infertile. So please, once we are here, I think it's part of the advocacy that we can be doing. Thank you.
Thank you very much, Benjamin. Hopefully, this discussion will not end here, I know. But once it is anecdotal evidence, we can go to the field to do good actual data collection, and then we can talk about this issue. Because I have the microphone, please give me 1 minute to make a rendition. So, I work as the national coordinator for the Ghana CSOs platform on SDGs, and about 570 civil society organizations belong to this coalition. It is a coalition that does not get funding from its members, and largely it doesn't seek funding. What the framers of this coalition decided to do is to align their work to support the achievement of the SDGs in Ghana. And one modality that we have used to... So one of the modalities we have used to support our own initiatives is that organization A, B, C, D to up to M, they are all working on a thematic issue where they receive funding or they source their own funding. Then what we do at the Secretariat is to look at a national work plan. And then once we have agreed on the work plan, we share it with these civil society organizations because they also have their individual work plans so that we can align. So a typical example is on the menstrual hygiene campaign. We do not have funding, zero. But what we do is that we want to do A, B, C, D by the end of 2026. So my work plan goes out very early, and then I send it across to the organizations, and then they begin to tick that we can fund you in this, we can do this, we can do this. The money does not come to me. So the day we agree to do the activity or the duration of the activity, what they do is that I'm providing you with chairs, I'm providing you with water, this one says I'm providing, they bring their resources to the location. They spend there, and then each one takes their own budget and then they go away. So at the end of the day, we have collectively implemented an activity that the Secretariat did not receive 1 cedi, but we ended up spending 100,000 cedis on that activity because ARHR contributed 10,000, NOSA contributed 5,000, PPAG brought in 20,000, and then the activity is done. We do surveillance on sanitary pads. It's basic, right? So we call our young people, you are all over the country, whether government gives you a pad or not. At the end of the month, you will menstruate and you need a pad. So when you are going to buy your pad, just take a snapshot of the price of the pad. If you bought it from the supermarket, or if you bought it from a Yamame store, write the amount you bought it, attach it to the pad that you bought, send me a picture of it, and they willingly do it at no cost. If I don't have money to send them 20 cedis to buy the sanitary pads, they themselves, once I make the request, they buy the pads and then will send me evidence of purchase so that I can use that one to generate the data that I need to speak to policymakers. This is how we do resource mobilization at a very minimal cost. I'm saying this on the ground that the think tank has come to stay. We need our collaborative and collective efforts to ensure that our collective objective will be achieved. So if you have something that you are doing, please call us. You may not necessarily give us the money, but if you let us know that this is what you are doing, we are also able to monitor from the Secretariat, and then it adds to our data and then eventually our collective outcomes. Thank you very much. On this note, I would want to invite back to the podium Professor Zulfiqar Bhutta to give us a synthesis and the way forward. Prof, you have 10 minutes to do this for us. Okay, I'll be monitoring you.
So thank you very much. Thank you. I absolutely don't intend to take 10 minutes. It's been a very rich morning, and I know I'm standing between all of you and lunch, but it's been a very rich morning. So I've heard not only a lot of enthusiasm for the work, but also a lot of enthusiasm from all the participants on the continuation of something which would be better than the status quo. And the status quo is also changing in the background. So to cut a long story short, Ghana has made progress. Ghana has made tremendous gains around the traditional maternal child health indicators, nutrition indicators. But the world of the Sustainable Development Goals is a lot more complex. These are only just components of what is out there as SDG targets, SDG indicators. And if you look at the totality of the issues and challenges, Ghana still has a long way to go. Long way to go in aggregate progress and also in reducing disparities and differentials between various parts of the country. And I'm not getting into those details because they will be in the report as to how to reach people who are marginalized, also either on the basis of geography, whether they live in urban poor settlements or they live in rural remote populations. So this is to a large extent a government initiative and responsibility to ensure monitoring, evaluation, data collection, and also, importantly, acting on the data. So data which is collected just for the sake of what we call intellectual voyeurism, just looking at it, admiring a problem, and is not associated with action to address that is a tremendous wasted opportunity. And I don't think it does anybody any service. So I would make, number one, the case that all data for decision-making should be functional, meaningful, and associated with action. Secondly, data and action are not in isolation. So there is a huge opportunity for public-private partnerships, government, non-government sector partnerships in this regards. And there are plenty of examples of how it isn't an either or us versus them. It is all of us together. And the global landscape that has changed in terms of development assistance, the largesse of aid money flowing into many countries, has in some ways been a silver lining for national ownership of targets, national ownership of initiatives, and also accountability. And the last point, the accountability part of this, is extremely important. There is no other way. Just like without exams, no student studies. Without accountability, no program manager or policy maker at national or subnational level actually feels the necessity to deliver. Now, let me finish by just raising a few questions for which I don't have answers right now, but I certainly would encourage you to start thinking about this. So David and Fred had asked me to talk a little bit about how do we sustain these kind of initiatives. Now, by the way, the resources that we made available to David and Fred and their think tank team were very modest. For the kind of work that they needed, this wasn't hundreds of thousands of dollars. This was very modest funding, and it was deliberate in some ways because you need to be able to learn how to do more with less. We also had very modest funding ourselves, and we all sailed in the same boat together. Now, 5 years later, I think that was a very smart move at that time to try and do more for less. So how do national initiatives like this, think tanks, function without significant funding? So first of all, they cannot function without funding. Somebody has got to provide some resources, whether human resource or a small amount of funds for communication or networking. But my experience is that that level of financing and funding is almost always available within countries themselves, if not from the government, from the private sector, from universities, and importantly, from something that you should very actively consider. So think tanks and networks are voluntary. We are all part of societies, associations, and big health professional networks, where we all put some of our skin in the game through subscriptions. So I think academic sector within Ghana ought to be able to put some resources together to sustain and maintain this network, not just for addressing and monitoring existing sustainable development goals, but what is going to come after the SDGs. So today it is January 2026. The SDGs will close September 2030. So the 4 years remaining will fly like this. It's actually less than 4 years. So already people are beginning to think about what is going to be the state of global compact going forwards. And I can tell you a few things. The thinking right now is it ought to be owned by low and middle income countries themselves. We cannot depend upon high income countries, Europe, North America, others, to sustain an initiative which is largely to benefit low income countries. There is also a thinking that Africa needs to come up with something which is for Africans. And it's also very important to note that there are already organizations in Africa working on that. You have a CDC, you have an African Academy of Sciences, you have lots of networks, and importantly, you have political leadership, which can also address this. So I think you should start thinking about how you sustain this within Ghana through your own efforts and academic networks, how you bring the government on board on side. And I would suggest that not as a funder, but as a collaborator, because you don't want to lose your independence or autonomy. And third, that you look at local, we talked about the private sector or the industry, but we didn't talk about philanthropy. Some of the most important philanthropic efforts in Africa are by Africans. And I don't want to name any, but I know of several which have funded initiatives to the same level as other foundations elsewhere. So I'll leave you with these thoughts. But my hope would be that in 5 years' time, when we come together at some stage at any forum, in terms of looking at the post-sustainable development goals world, whatever that may look like, whatever that initiative might look like, that it would be an initiative for Africa, supported by, run by, and also owned by Africans. Thank you.
Okay. Yes, please. So I'll hand over the microphone.
Can I do just a quick acknowledgement, not a vote of thanks, but I think that should suffice for all that. We really want to appreciate Professor Bhutta for the role he played in putting us together. And we are very, can we give him a hand of applause? I said that in my already a very important collaborator for us in this space, and we've already looking forward to working with him in other spaces also, as I said, climate change and health. So we are very grateful. And as you heard him, there was just very, very little resources for this. And our think tank members nobody gets paid a cedi for the 2 years that we've been running. So it has been very voluntary work. And we want to give a round of applause for our think tank members for the great work that they have done. I want to single out the institution. I want to single out UNFPA and then NDPC. Represented by Dr. Jan and then Mr. Okra. We are very, very grateful. They've been a very key fulcrum through which this was revolving. And NDPC offered us free of charge almost all our meetings for their conference room and facilities, and we are very, very grateful to them for all. And these are the kind of collaboration that we could foster in the future if we don't have resources to rent a place like this. And there are cozy places in University of Ghana or in UAPA or in Ghana Health Service or in WHO. We could open such doors for us for gathering and meetings of this nature. I want to thank every one of you for your time. We know you have a very heavy demand on your time, but you deemed this very important and you took time off this heavy schedule to be with us. We are most grateful. Thank you very much. This is not the vote of thanks. This is just my acknowledgement. So I'm very grateful. Thank you. I should say also Professor Atuama, who has been the convener for this. We are very grateful. Thank you, Prof.
Thank you very much, Professor David Teye Doku. I wanted us to have a little stand so that we can stretch before we come to the beautiful voice of the afternoon. Please, can we just rise? And then, Barbara, please, will you have something for us? Just... please don't hate me for calling Labram again. Labram, come.
So just do a very simple one, right? I mean, this one for the app, right? So we just, just as Prof said, just thank everyone. So I also appreciate all of you by giving you a hug, right? So we'll hug ourselves, right? So we'll do like this. Good. 1, 3, 4. Hug yourself. 5, 6, 7, 8, 9, 10. 10. All of us.
9, 8, 7,
6,
5,
4,
3, 2, 1. Oh. No, you don't know how to count one. It's only one. Thank you very much. Please, shall we take our seats and go over to the beautiful voice of the afternoon? You want to come? Okay. Dr. Esther Odra Ofe Abuaji.
Well, there are a couple of Thomas names that didn't make it here. But thank you very much for the opportunity. In fact, after Prof spoke, I said, good, we're going to have lunch and then we'll go home. But never let it be said that I was given the opportunity and I didn't take advantage of it. Yeah. One thing about growing older, I don't think Eric Okra has read there yet, is that you don't get out often. So when you get out like this, then you are very excited. Then somebody asks you what you went to do and what you heard. And I must tell you that I've had an exhilarating morning, very insightful, number of thoughts in my head, and a couple of issues that I wanted. I mean, I think Prof Armah set us off on a good note when he reminded us that health was important for social stability, economic transformation, and resilience. And I think if he aimed at having us do a stock taking and cross-fertilization and ideas on the pathways, I think he definitely has succeeded in that objective. I'm also very pleased with the journey down memory lane that Professor Bhutta took us, the formulation of the MDGs, the blind spots, as he indicated, in global epidemiology, geographical inequities, social determinants, and the issue of pandemic preparedness, the value of think tanks, and also the issues around continuing to do demographic health surveys, the issue of the human response, and the nexus of conflict, nutrition, food insecurity that he drew our attention to. And the issue of national level commitment, sustaining it. And then in my own two key areas, social protection and devolution, decentralization. And those of you who know me know that that's where I've spent quite a bit of my life in the past. We listened to Professor Teye Doku with much pleasure and quite a lot of information. The issues about how we have participated, how we've performed, and what we've done, bringing diverse institutions together, tracking performance on the SDGs, and where do we go from here? Where do we go from here to be able to fuel a think tank and also collaborate to access resources and data? We listened to the National Development Planning Commission. They said all I wanted them to say, including the fact that an area like maternal mortality has attracted presidential interest. And UNFPA is also working with the SDG Presidential Advice and a few other key partners to actualize this. And I wanted to say that part of their discussion, because as a fly on the wall, does cater for the mental health aspects of maternity and that process, the issue of psychosocial support and where all of this comes in and giving it better recognition and understanding. And so we can look forward to something very, very promising in that regard. The issue of primary health care, all the initiatives, CHIPS market and transport station clinics, and so on, and all of that, which, if we are able to actualize, should set our country on a very interesting trajectory. The four main inputs, UNFPA, again, like I said, I was very happy to think through such things as the multi-sectoral partnership on fistula, and then also the efforts to look at issues of procurement and supply chain, last mile delivery. All of it was interesting. The area of interpretability of data, I have a lot to say about that and a lot to think, but this is not the forum or the place to share all my grievances on that matter. The issue of mental health, the issue of persons with disability, access to data on monitoring and tracking impacts on persons with disability is something that we should take seriously. In fact, our fight on disability has not been good. With the passage of the law and then enhancing access, and he was talking about people, the building, just like when you go to some places, where even social welfare is located, is in some pre-colonial building. And it's coming apart. And it's very disgraceful. It's very, very, very disgraceful. To me, I feel shy when I talk about our fight on issues of disability and the notion that pregnant women, just because they are hearing impaired, have had their lives impacted on is one of the sad things I'm taking with me today. I was intrigued to meet the Green Africa Youth Organization. I'm not sure I know too much about it, and I'm really intrigued because of the issues that they are working on: climate action, youth leadership, resilience, job, just transitions, and clean jobs. I mean, there's a lot going on there that we should be interested in supporting. And the issue of youth-led initiatives is something that I think we should really champion with what we are doing as a country. And the issues around traction and policy execution also caught my eye. With ARHR, I've sort of journeyed with them. The issue of rural-urban disparities and so on is something that we should take very seriously because it buys into my own areas of interest that I would like to say. I want to congratulate Labran. I mean, he harvested quite a lot of good stuff that we are working on. The role of industry or private sector in public health and public sector delivery, the issues of the withdrawal of donor funding as an opportunity for local capacity development, and the issues of data, the universities and data, and how it can improve interoperability. I think we should commend the Ghana Statistical Service. I have a lot of respect for that organization. And even they are very helpful. They've been very helpful to me in my work in the sense that when you want something and you want to customize, they can actually help you do it. There's also a lot of data in their services. The Ghana Health Service and the Ghana Education Service and even Agric. We need to be intentional about some of these things. But, Levlin, if you continue collecting the data the way you described, some of Professor Teye Doku's colleagues will tell you that the data is not rigorous, it's not robust enough, it cannot be committed. That's what they will tell you. That's what academics will tell you. But the point is the issue of capacity, the issue of interoperability, the issue of standards, and the quality of the data. Leaving here, I think all of us have to strengthen our advocacy around population and demographic health data, that our governments should try and fund it. Why? Because the methodology will stand international comparison. And let me say this, as an old woman, and a very cynical old woman, however good your work is, sometimes if it doesn't match somebody's standards, the data is not good. You see what I'm saying? However good it is, until you have something that is able to match what are internationally acceptable standards, will be difficult. So we have to encourage our governments to make some investment in this area, you and I. Which brings to my last point, which is about Professor Bhutta's comments about sustaining the think tank initiative and all of this very good work that's going on. He identifies some potential sources: government, philanthropy, private sector, academic networks, and so on. They are very good sources that have worked for others and could very much work for us. But it is important for us to recognize that people will put their money where they have faith. People will put their money where they prioritize. If you don't know anything, let's look at how people go to church in this country. You know, the way people raise money at church and so on, it's because the people think that they can get something out of it. So when they say donate, then we donate. When they say buy, then we are buying. If we are able to make a strong case for investing in health and also thinking about health, strategizing and sharing about health, we should be able to win people to our cause. So it's for us, you and I, to go from here to do advocacy on this that we've done and learned today and talked about today, so that people will be happy to support, people will be happy to donate their time and energy, for this course. I thank you very much for your attention and for the opportunity.
Thank you, our favorite Auntie Esther. Okay, so on the think tank, there is this young lady, and she is in the person of Miss Ifua Nyameche from the Green Africa Youth Organization. I don't know how she does it, but somehow she does it and still volunteers. So Ifua, please close us so that we can leave here in one whole piece.
Thank you very much. It looks like the one between us and lunch, but today has been very insightful. I've learned a lot. I've heard wonderful things that I didn't know about. So we are very grateful to God for this convening and bringing this thought in the mind of our convener for us to organize this. It's been very meaningful to me, especially. And our next gratitude is to our chair. She's been in her seat. See how she synthesized everything that we talked about. She's been listening and she helped us run this event very smoothly. So we thank her for her time and dedication. We are really grateful. And also to Prof. Bhutta, from the beginning, your initial presentation, even to the end, like there are a lot of things that you've given us to take home, to reflect on, and to work on. We are really grateful for your time and effort. To our convener, Prof. Armah, also to Prof. Teye, Doku, you were thanking everybody by leaving yourself. You guys have done a lot of work putting this thing together, and your dedication to the think tank is amazing. And to my other colleagues on the think tank, I think there's a whole work, like being up and doing and putting people together. Gladys is not here calling people and making sure that all of us come together has been really meaningful. So thank you. And it's been very rare for us to have an event and at the end of the day, like getting 1 minute to closing and everybody is still seated. This shows how important this discussions has been. So please clap for yourselves. Yes. We are really grateful to have you today and your contributions, very meaningful contributions. If we were left, everybody would have spoken in this room. That shows how we want to collaborate and partner on such very relevant issues on health and health-related SDGs. So thank you all for coming, and we are really grateful. We know that next time when we call, you come and you partner with us in very grand styles. Thank you and have a wonderful day.
Thank you very much, Ifua. So, please, is there any Muslim here apart from Mr. Labram that I should know? Okay, the rest of us, we are. Your hand is up.
Right. So, yeah. Right. So, can we be upstanding? For me, irrespective of. If I'm an advocate, and I always want to be an advocate, right? So, in the interest of the various religious groups are here, I would just say that if you can just commit maybe 1 minute, so that we pray for our country for whatever we've done here, and also as we go home, we pray that God Almighty take us to our various destinations in good peace. So we can start now, your own self. We say amen and amen to this. Thank you very much for accepting to go through this prayer with me. And I pray that we will translate whatever we have done into meaningful action. Thank you.
Thank you very much, ladies and gentlemen. And the last bit is that my name, beautifully, it's Levlin Punedu Asiedu. I am a member of the think tank, and then I am also the national coordinator for the Ghana CSO's platform on sustainable development goals. It's been a pleasure being your MC for today. Have a pleasant afternoon. Bye-bye.